and ocular surface disease. And this is a joint meeting between KKESH Global Education Forum, Pan American PanCornea, and TFOS. So now, because of the time, it's already 5:05, we will start. I'm gonna carry on Jose Gomez, who will introduce the first three speakers, and then he will moderate the session. Thank you, everybody, for accepting the invitation.
Thank you, Jose. Thank you, my friends from all over the world that are joined here in this wonderful global webinar. We try to do the best so we get the best people of all fields in ocular surface. And we are going to start with Professor Victor Perez from University. Victor is a scientist.
Oh, we have to do this because I wasn't able to do it.
One of the most knowledgeable specialists in ocular surface and dry eye. And Victor is going to start with this topic, clinical treatment for dry eye. Someone is, Jose, can you turn off the micro? There's a little noise here. Okay, Victor, please, the ball is with you. Just before Victor starts, just a review of the program. We are going to have 3 lectures about clinical treatment of dry eye. Then we're gonna have a discussion with the 3 speakers that are gonna last 15 minutes. And then after that, we're going to start the surgeries, starting surgery for dry eye and then ocular surface reconstruction. And then we are going to finish with the keratoprosthesis. And after that, we're going to have a few cases presented by Hernan Osorio from KKESH. So I hope everybody enjoyed today, this morning or evening or afternoon. So we're going to start with Victor. Victor.
Okay, Jose, can you see my screen?
Yes.
Excellent. Well, thank you for organizing this great seminar, and I echoes Jose Square Vargas and my brother from Brazil. Welcome to the seminar, and I hope everyone is safe, and hoping to see you guys soon. Jose asked me to put together upgraded clinical treatment for dry eye, and I figure to focus on one of the strengths that my laboratory and my clinical practice is, which is inflammation. As other topics will be covered by some of the other speakers in the session. So, you know, these are my disclosures, but certainly as we has that continue to be part of the definition of the dry eye by the DUS panel of TFOS, which I want to welcome again for being part of this seminar along with KKESH and PanCornea. Surface inflammation and damage continues to be a very important part of the mechanism of disease. So as we think of how we're going to upgrade the treatment of dry eye all over the world, I really believe that focusing on inflammation is very important. I'll show you some data for that. Not that I want to bore you either 11 o'clock at night or at 7 o'clock in the morning here in Miami, but if we're going to treat inflammation, it's important to understand what we're dealing with. And the ocular surface is a very smart inflammatory unit. As you can see from this diagram, adapted, wow, we did this a couple of years ago in our dry eye initial panel looking at inflammation. Everything starts in the ocular surface, either is desiccating stress or an allergen or any other insult, but normally the corneal epithelium, the conjunctival epithelium are being attacked by these signals, and they are the first line of defense, and they release cytokines, MMP9s, etc., to try to maintain our homeostasis. The cells that play a role here mostly are macrophages and neutrophils, I'll show you. So as you're thinking of your treatment of patients with dry eye, patients that may have what we call flare-ups or episodes of exacerbation of the dryness, it's this population of the immune system that we call innate immunity that might be in play. So drugs or anti-inflammatory therapies that will reach out to this population of cells will be smart to use for these forms of dryness or symptoms of dry eye. However, in chronic, and we want to believe chronic patients, as this mechanism continues to occur throughout time, there's the activation of what we call antigen presenting cells that bring some form of antigen from the ocular surface to the lymph nodes. In the lymph nodes, which we know are in the neck that drain the ocular surface, this is where the other wave of inflammatory cells begin. And this is what we call the adaptive immunity. Mostly the main player of this type of response being the T cells. And there are different population of T cells, they're antigen specific. And with time, these cells start migrating throughout the body, including the ocular surface. And because these T cells are antigen specific, or in other words, they recognize antigens from the ocular surface, as they go through the ocular surface, they'll migrate, they stop, they get recruited, activated, and enhance or prolong the effects of inflammatory damage by the production of cytokines of the ocular surface and damage to the structures. So when we start thinking of therapies that we take care of this part of the immune system, here where we think about T cell inhibitors, which are the main drugs, at least in the United States, approved for the drug of by the FDA for the treatment of dry eye, and also medications that will prevent the recruitment of these T cells into the ocular surface where they're activated. And I believe, and I'll show you that at the end, that the future of new anti-inflammatory therapy will be drugs that target cytokines, or more specifically, the activation of T cells. So when we think of this, the area of inflammation, I can share with you from the experience in our center at the Foster Center for Ocular Immunology. We don't have a great biomarker for inflammation, but we have a very good one, and it's metalloproteinase 9, first discovered and associated to the development of dry eye by Steve Fluchfelger now in Houston. And with this test from Kydell, which is called Inflamadry, we have it in the United States and I think certain parts of Latin America, I'm not sure elsewhere. I know in South Korea and in Asia, it's kind of like a test where you take tear collection, and if the patient is positive for MMP9, metalloproteinase, which is thought to be released either by inflammatory cells that are present on the ocular surface or by cells in the ocular surface, and it's thought to lead to damage. If that metalloproteinase is present, this test will become positive. It's kind of like a pregnancy test. The limit of detection is 40 nanograms per ml, so it's very sensitive. But taking that in consideration, we've used this in measuring all our patients in my clinic, and data generated by my clinical fellow, Matthias Seufer. When we look at all our patients in our practice, we have a large patient of patients that are autoimmune disease. And this is kind of like a proof of concept that this marker do measure inflammation in the ocular surface. The big majority were positive for MMP9. And most of the autoimmune patients, you can see them in this list. What is very interesting is when we look at MMP9 at the beginning, when they present to our clinic, and 6 months or a year later, patients that were MMP9 continue to MP9, with the exception of some that were treated with anti-inflammatory therapy. But what is interesting, patients that were MMP9 negative eventually will become MMP9 positive, saying that if you have a population of patients in your practice that you measure metalloproteinases, which can be used to monitor the progression of inflammation at least, and we have some preliminary data I'm not showing, but also progression of disease, this is a good marker to immunomodulate. What have confirmed for us the important role of inflammation is some work that I've been doing with my collaborator and plant scientist at our center, Dr. Danny Saban. And what we've done is we've taken tears from all our patients and also ultrasound fluids from the ocular surface and inside the eye. But the big point has been that we try to create a personalized or identify the immune signature of these patients. So what we can do is actually take single cells from the ocular surface of these patients, do what is called single cell RNA sequence analysis. In other words, we can take this RNA from each cell present and do high parameters flow cytometry to identify new cells that could be present in the ocular surface. And what Danny has done in our center, collecting tears from patients, we run a high parameter flow cytometer. So cells are stained, they're run through this laser, and we can do up to 80 colors of markers on the ocular surface. And what we just published in Science Translational Medicine is that when we take the tear fluid and cells from patients with meibomian gland dysfunction and do what we call tear cytometry, and we can do from the hair treatment fluid analysis for the single cells, we identify their population of myeloid cells that are not only macrophage, but also polymorphonuclear cells, more specifically neutrophils. So now we're identifying a new population that goes beyond T cells in the surface of ocular surface disease patients that could be part of that inflammatory milieu. So as we prepare and develop new therapies, this is a population cell we might need to do. And by doing what is called unbiased T-SNP analysis, in other words, what you're seeing here are each dot is a cell and each color is from a patient. We have 5 subjects and we can actually identify what population of cells belong to each. And you can see that there's a big difference or a population of patients within the MGD population of tears that in contrast to normals have a very unique signature. And this is what we call cluster analysis. So now we're looking and try to identify not only do we have these clusters of neutrophils, but other cells present, at least at MGD. So as we move into the future, we hope that this becomes a new tool to identify new methods and methods of inflammation. So how we control inflammation and upgrade your treatment of patients with dry eye? Well, the most common and most effective one is the use of steroids. And I love the use of steroids in the treatment of dry eye. They need to be used carefully, of course. And with Steve Fluxferger, once again, that shows that in patients with Stevenson-Sjogren syndrome with keratoconjunctivitis sicca, the use of methylprednisolone therapy was effective in the treatment of both signs and symptoms of dry eye, but of course with the problem of high intraocular pressures. So the future, I believe, of using of steroids, and when I think of the use of steroids, I think of that flare up or try to treat the acute innate immunity, which takes care of this potentially neutrophils as well. The closest thing is to develop smart steroids, steroids that will not have complications. Loteprednol probably is the first, well, probably is the first generation of this. And Steve Fluxferger once again had a very nice study, randomized masked prospective study where he treated dry eye patients with loteprednol, 0.5%, and showed that patients improved both in objective and subjective symptoms without the complication of increased intraocular pressure. So as the future moves forward and we upgrade our treatment of dry eye, right now in the United States, the company Kala has been approved by the FDA for the use of Ineveltis for the treatment of flare-ups of dry eye. So Kala has created this nanotechnology where loteprednol at lower concentration or lower concentration can be targeted into the tissue. And these nanoparticles actually are absorbed better by the conjunctival mucosal cells and create kind of a better depot with probably more effectiveness. The data looks very promising, especially for the treatment of flare-ups and dry eye. And I foresee this being one of part of our armamentarium for the upgrading of treatment of inflammatory dry eye. And of course, we go back to the T cells. And we've learned, probably this is the standard of care that demonstrated that dry eye has an inflammatory component. I mentioned the T cells. These are the population of T cells involved in dry eye. I don't need you to remember the subtypes, but these are effector cells. And it's through the cytokines that they produce that they cause damage and exacerbate changes of the ocular surface. So the cells that are known to be part of the ocular surface, dry eye, the adaptive immunity milieu are Th1, Th17, and they make cytokines that cause that. And one of the most effective drugs that we have had to block T cell activation in the ocular surface, not only in dry eye, but also in other inflammatory ocular surface diseases like allergies, is cyclosporin. In the United States, we have 0.05%. I know that elsewhere in the world, you have higher concentrations. Cyclosporin is anti-inflammatory, and even blocks T cell activation by blocking calcium channel, calcium pathways of activation. So it really prevents the activation of T cells by preventing the production of IL-2. The use in dry eye has been well documented. Probably more groups around the world have more experience than many people in the United States with higher concentrations than I just mentioned. And we know these caveats. It works in a population of patients. It's not every patient. They have their side effects with irritation because how to get it under solution. And I think most of the advances in the use of cyclosporine have been a combination of new vehicles, new nanoparticles that you can afford, increased concentration of cyclosporine. And I think that will continue to be an armamentarium for the patient of dry eye. Tacrolimus or Prograf, it's another calcineurin inhibitor, excellent in the treatment of dry eye. I use it as part of my armamentarium when I don't have good effect with cyclosporine. And in some instances, like allergy, tacrolimus have a very good track record in controlling T cell activation and other cells associated with ocular surface inflammation. In the United States, we have it only as an ointment for dermatological purposes. I know elsewhere in the world, it's being formulated, especially in Japan. And we're hoping that this is another anti-inflammatory that's picked up and formulated in a commercial fashion. In the United States, we have opened the doors to the treatment of dry eye using what is called anti-integrin therapy. When there's ocular surface inflammation, these proteins called adhesion molecules, the major one known as ICAM or intracellular adhesion molecule 1, it's upregulated by the corneal epithelium, conjunctival epithelium, blood vessels in the conjunctiva. And what it does, it tries to attract those cells, those T cells that are being circulated. The recruitment of those T cells, as you remember, was part of that process. So when T cells are, these activated T cells are circulating through the ocular surface, if they see ICAM, they will get recruited into the ocular surface, get activated, and produce the cytokines that cause damage. So targeting this pathway makes a lot of sense to try to prevent the damage caused by chronic activated T cells. So these chronic activated T cells express these receptors called LFA1. It's got the company initially Shire and now obtained by Novartis, made the product called Lifitegrast, in the United States known as Xiidra, 5%. And it's an antagonist that blocks the activation and recruitment of these T cells by blocking the interactions between LFA1 and ICAM. So when an activated T cells comes to the ocular surface, it recognizes ICAM, gets recruited and activated. And with this new asset, we're blocking both pathways. So with cyclosporine, hypothetically, we're only blocking activation. Here we're blocking two steps. It's only recruitment and activation. So Xiidra was approved in the United States in 2016. It took 3 clinical trials. The experience was impressive enough to get the approval for the treatment of signs and symptoms of dry eyes. So for some reason we still don't understand, the improvement of symptoms also is associated with the use of this compound. Our experience in our center have been very similar to the one of the clinical trial. There's a population of patients that works excellent. There's a population of patients that will not work as well like any other drugs because they're probably different mechanisms of action. But it really has become part of our armamentarium for those patients that usually have more symptoms than sign of dry eye, and we'll continue to learn from the use of these compounds. But what we also learn is that we need to be more focused as we move in the future and we upgrade the treatment of dry eye from the anti-inflammatory point of view. And one of our key players, as I mentioned, are the cytokines produced in the ocular surface. So what about anti-cytokine therapy? Well, in the United States, we have one company called 11 Bio that had a very nice technology where they can actually engineer very specific monoclonal antibodies against certain specific proteins. Their prototype was isonakindra, AB1005, which blocked the IL-1 receptor inhibitor, one of those other cytokines. Unfortunately, the phase 3 data was not robust enough to be approved, but it did open the idea of using and developing antibodies that could be used to block cytokines that are harmful to the ocular surface in a more direct way. And in our laboratory, we've actually been working with kinase inhibitors as well as potential new cytokine inhibitor tools. So the take-home message is that evaluation of the ocular surface should be like columellus. I did not present that. I want to make the point that anti-inflammatory therapies, inflammation is a key point in the treatment of dry eye and the pathophysiology, and the development of new targeted therapies will help optimize the inflammatory cascade for our patients. And it should be kind of like a, building block. You go from steroids to control acute inflammation and other T-cell inhibitors and new pathways to prevent chronic disease. Thank you.
Thank you very much, Victor. A wonderful lecture. I ask the people that are getting in to ask direct questions for you, for the speakers. So please, speakers, pay attention to the questions. And I'm also writing some questions. So we are going to discuss this after Jennifer's talk. So the second talk this morning or this afternoon or evening is by Professor Jorge Alió, who is professor and chairman at the Miguel Hernandez University, the chairman of the ophthalmology department, and founder of the scientific director of Vision Corporation. Jorge, it's a pleasure to have you here. And Jorge is going to speak about the hemoderivates, especially the PRP. Thank you.
Thank you very much indeed for this presentation. And thank you for the invitation, Jose, because it's very nice to be that much international in such a sunny day like in Spain. It's now 1 p.m. and I'm happy to be with you, with this topic, which is the use of PRP, platelet-rich plasma, in ocular surface problems and dry eye disease, which I will develop in the next 15 minutes. First of all, we know that we are using in treating ocular surface disorders a variety of autologous blood-derived products. And the three that are at this moment on the stage are autologous serum, which is the one more in use, plasma-rich in growth factors, PRGF, and preparations rich in growth factors are indeed one of the commercial ways to use at this moment these hemoderivatives. But what I'm going to talk to you now is about plasma enriched with platelets. This is a distinctly different treatment, and I'm going to explain to you our experience and the rationale behind the use of this treatment. The base of the treatment is the use of autologous serum, in which, as you know, we create a serum that is a clear part of full blood that following the clotting has no platelets, and so basically the autologous serum is a no platelets supernatant, following centrifugation with no type of anti-clotting system. Then it is diluted in different concentrations and in different products as well. And this is what is generally used in the treatment of dry eye disease and ocular surface disorder. Then PRGF is different because sodium citrate is used as anticoagulant. So this is the main difference. The blood is not coagulated, but the preparation of this type of product requires a special lab with an endored system. Is a commercial device that creates the product. The product is diluted as well. It's diluted 50% in 0.9% sodium chloride, and the tolerance has been reported as good, and the treatment is effective to reestablish the corneal epithelial surface. But we're talking about PRP. And PRP, ePRP is iPRP, is the PRP that we have been using for the treatment of ocular surface disorder since about 12 years, and which is the amber color and slightly turbid blood fraction that is obtained at the centrifugation of uncoagulated total blood with sodium citrate. It's very rich in platelets, growth factors, and clotting proteins, and it is obtaining one-step centrifugation process, and it uses commercial use, and is used, and it requires only a laboratory centrifugate. So we don't need specific devices, which makes this product very cost-effective. It's available in any hospital, and it's very easy to prepare. We can prepare PRP in 3 different ways. One is the fluid, the drops, in which we use the PRP directly from the supernatant, and we use the bottles to be instillated in the eye. Then we can make a partial clotting of this product, creating a solid clot. This solid clot is used for surgical treatment. We can discuss this later. And this we can, from the platelet pool plasma, because in the supernatant you have the platelet rich plasma, but inferiorly you have the platelet pool plasma, and this is used to coagulate fibrin, and we use the fibrin as a membrane, substituting the amniotic membrane. So these are the three products that you can create with the blood using this way to prepare either the fluid, either the solid clot, or with the platelet pool plasma to create a membrane to substitute a totally amniotic membrane. You can use at this moment this product, or you can obtain it from commercial technologies like this one. This is the Radiant Kit. There's another one like the Angel. Angel is very popular in many countries of the world. They are closed systems, and you have to take the blood sample, and then the rest is done by the machine. This is another one, the Glow PRP. The Glowfin is a Finnish company. All these are very effective, but you have to know that the amount of blood that you need is larger, and you have a less effective treatment in getting the PRP. So basically, the one that we do, or you can do in your lab, is more effective than these devices, even that these devices have the advantage that they are closed systems, and they are very much practical for the use for ophthalmologists who are not working in a clinical hospital. So we reported for the first time use of the autologous platelet-rich plasma preparations in the field of ophthalmology. This was used in cases of chronic dormant ulcers, dry eye, and ocular surface syndrome after LASIK, and there are the three main indications in which we use this product now. So the first question is why we use platelets. Platelets are, as you know, are great reservoirs for growth factors, and growth factors enhances proliferation and wound healing in both soft and hard tissues. We have a different type of products in the platelets, and the platelets are in this system activated, and we are using the platelets onto the eye. And having activated platelets, you have this system that they release all these products and others onto the surface of the eye. And this is what we described in this first paper that published in ophthalmology in 2007, now 13 years ago. What the products that we have in the platelets, we induce chemotaxis, cell proliferation, cell differentiation, neovascularization, and we increase the production of intracellular matrix. In other words, they induce a lot of advantages, including the migration and proliferation of the epithelial mesenchymal cells to the cornea, and this makes this an ideal product to restore the integrity of the ocular surface, not being only a lubricant, but being also a biological activator of the ocular surface. And we have recently characterized and published in Translational Vision Science and Technology the PRP type that we use. It contains an increase in anti-inflammatory cytokines, as you can hear in the slides, and a sharp decrease in the pro-inflammatory cytokines. It's interesting to know that these products and the activation of these products and the presence of them in the PRP is increased with time. You have ultra freeze the bottles, what means that with time the increase in the efficacy, which has been a quite understanding. So you can read this paper that has been released in 2019 from us. So you can use as a summary topical eye drops, solid and autologous fibrin membrane. Let's focus now in the use of autologous eye drops. The plasma is obtained on centrifugation, and they are placed in the sterilized 10 milliliter glass bottles that they are used for 1 week. The conservation for the patient is 1 week at 4 Celsius degrees, and 3 months should be for -20 Celsius degrees if the patients want to have them for a while. The indications that we find now, and you can find in our papers, are persistent corneal epithelial defects, dormant corneal ulcers of different etiology, chronic punctate keratitis as the one that happens post-LASIK, and you have as a clot and associated also to the fibrin membrane in case that you want to close a perforation, in impending or declared corneal perforations, macroperforations, and a variety of problems in which either from traumatic or from chronic surface eye disorders, you can use a very effective tool and very cost effective with this preparation. We have reviewed the samples of 1,352 samples from 585 patients. As you see, the main indication for us is dry eye, especially severe dry eye. This is 59% of our cases. Ocular surface syndrome post-LASIK is the 14%. Ulcers and perforations were a total of 26%. And other indications are also used as a diversity. In terms of ulcers, we have 12% of them were neurotrophic, and chronic epithelial disease happened to be in 11% of the cases. Let me focus now in severe dry eye syndrome, which is the topic of this webinar. We had, in these cases, classified and studied. We canceled all the medication 48 hours prior to the PRP treatment, and we use the treatment for a cycle of 6 weeks, up to 3 months in these cases. This is a summary of our outcomes. We can discuss this later on. As you can see here, subjective improvement in the symptoms happened in 88% of the cases. 30% of the cases gained lines of vision. Fluorescein staining was significantly reduced in 83% of the cases. The third meniscus was increased in 78%, and the hyperemia was decreased in 84%. So in general, the signs and symptoms of severe dry eye were very much improved by the use of this type of medication. These are just examples of how the patients are before and after. The most relevant improvement is in the symptoms, but immediately following symptoms is in the punctate keratopathy. Punctate keratopathy is the one that improves faster and better, and this is why these patients gain lines of best corrected visual acuity following the 6-week cycle that we started with this medication. You have punctate keratitis sometimes that are chronic and very specific, focusing in one sector of the cornea, and very chronic and related to exposure, and sometimes they are treated positively with this preparation in 6 weeks time. So as a conclusion of these papers and these studies, topically applied EPRP in patients suffering severe dry eye symptoms is very effective in 89% of these patients, improving both the symptoms and the clinical signs. These are the papers that you can read in BGO and Thermal Research, focusing particularly in the treatment of dry eye with this treatment modality. Let me now discuss a variety of dry eye, which is ocular surface syndrome post-LASIK. This has been a help for many, many patients and doctors, has been one of the reasons of discredit of LASIK, and is a distressful entity for patients and doctors. You have symptoms of dry eye with micropunctate keratitis, decrease on stable tear film, and it has a neurotrophic etiology. It's a long-lasting problem, and it's very difficult to treat. Lubricants only partially alleviate the symptoms of the patients, and you have these patients with a chronicity of the symptoms for a long time. We reported and published 80 patients with moderate and severe symptoms, and decreased from 1 to 4 lines of best corrected visual acuity. All of them had positive fluorescein staining. The T-BOD was decreased from 4 to 9 seconds, and the treatment outcomes after 6 weeks were reported. And these cases that were chronic, they came us referred after months, even years of suffering the problem. 85% improved in the symptoms, 47% gained lines of best corrected visual acuity, fluorescein staining decreased in 88%, tear meniscus decreased 74%, and hyperemia improved 92%. Outstanding outcome. This is one of the many cases we have in which you have these punctate erosions with a very bad quality of tear film that was improved highly significantly with a punctate keratopathy decreased or eliminated, and the consequent improvement in best corrected visual acuity. It's another example. And as a summary, we have in ocular surface syndrome patients a very positive impact in the symptoms, which are very important in the relief of the patient. Very positive effect in punctate keratopathy. The best corrected visual acuity improved modestly, but significantly in the group. The tear meniscus height improved, and there was a dramatic decrease in conjunctival hyperemia. So on the contrary, that happened in dry eye syndrome. This was hyperemia, which is obviously the inflammation that is related to this problem, with a punctate keratopathy that was much more affected positively by the use of PRP. You have these outcomes published in these 2 papers. The second, published in Journal of Refractive Surgery, focus on nerve regeneration using PRP, and we have been able to demonstrate that the regeneration after LASIK is not affected by PRP. This is interesting because PRP has a large molecules availability to the cornea that are all of them extremely positive for the recovery, but they are not recovering the neurotrophic part. So basically what we demonstrate is that they improve the epithelial damage, they will improve the lubrication, will improve the symptoms, but the nerve regeneration is not improved by this substance. So this is a kind of negative for the treatment of chronic neuropathic disorders, but basically it's very useful in this type of treatments, in this type of patients with ocular surface syndrome. Let me just show to you the beginning of the story, because we were looking for something to improve the dormant corneal losses when we were starting using the PRP. This is a pristine paper that was published with a description of PRP and its application in ophthalmology. As you see, we selected a very difficult group of cases in which many treatments have been used with negative results. The patient were chronic, and they were canceled all the medication 2 weeks, and then we start the cycle of PRP. A decrease or disappearance of the corneal fluorescein stain was observed in 69% of these patients that were with chronic dormant ulcers and non-responsive to previous therapy. 89% of the patients saw an improvement of their symptoms, very relevant as well, in parallel to the previous description I have. Some ulcers that became from a herpetic origin, becoming chronic and with a very negative impact in the symptoms, basically were also treated positively with the use of PRP. And some of these ulcers that were definitely torpid ulcers with a neuropath and neurotrophic component related to the herpes virus were the group that improved more, associated to the use, obviously, of antiviral medication with the use of PRP. So the combination of antiviral medication and this topical biostimulant of that is the PRP really made a double effect that really relieved these cases that were chronically affected in the ocular surface. Many other neurotrophic ulcers that many of them were of herpetic origin were definitely very positively affected, and especially those that happened following the use of steroids in corneal graft following herpetic disorders were definitely very much improved, and this became a standard treatment of hands. So in conclusion, we found in dormant corneal ulcers that 68.4% of the patients improved best-corrected visual acuity, gaining lines of best-corrected vision. 89% of the patients, which is 94.7% of the patients, which means 89 of them, saw an improvement of their symptoms, and 69% of the cases improved the corneal So as a global conclusion, EPRP treatment saw an improvement in vision, ocular surface healing, and vision of these patients affected by these very difficult the ulcers to treat. This has been published also in British Journal of Ophthalmology, so you can read more extensively everything I have mentioned to you here. These are two summaries that we have been publishing in different journals, in which you can see in pharmacological and pharmaceutical and biotechnology, and in this other paper published in Korean Opinion Ophthalmology, our summary about the use in these different disorders of IPRP, in the way that we use, and in the cases that we have been selected for the purpose. So EPRP is reliable, it's effective in cases wound healing processes in ocular surface disease, provides high concentration of essential growth factors and seal adhesion molecules by concentrated platelets in a small volume of plasma, and have in our hands a major role in wound healing and enhances the physiological process at the site of the injury, even in surgical cases, using this product in drops. Let me just remind to you that we have this university course that now we start the second period after 5 years of quite an important success on clinical methodology in refractive cataract corneal surgery. In this period of our lives in which we have to live online, these are 250 hours of teaching activities on these important topics, refractive cataract corneal surgery, that is available for all of you coming from our university. And I thank you very much for your very kind attention.
Thank you very much, Jorge. Excellent. We are moving now to Jennifer Craig. Jennifer is Associated Professor at the Department of Ophthalmology, University of Auckland, New Zealand. She's part of the TFOS board, specialist in dry eye, has done a terrific work, especially with the new devices. And that's exactly her topic today. She's going to speak about intense pulse light and thermal pulsation expression in the treatment of MGD. Do they really work? Jenny, thank you.
Oh, sorry, excuse me 1 second, just while I get to the start of my presentation would be good. Okay, well, thank you very much. I really appreciate the opportunity to give this presentation today, where I'm going to share some insights into some of the newer technologies that we're using in treating meibomian gland dysfunction. Oh, I'm not managing. Oh, there we go. So there are my financial disclosures. I work with industry rather than for industry, primarily in investigator-led studies. So dry eye, as you heard from Victor, the definition was published 2.5 years ago now. And we know that dry eye involves a loss of tear film homeostasis, and it's accompanied by symptoms, but it's multifactorial. And it's broken down into two main types, aqueous deficient and evaporative dry eye, but mostly it's evaporative dry eye that we see more than anything else. And in fact, 86% of dry eye cases involve an evaporative component. The TFOS GUICE-2 reports also describe the risk factors associated with dry eye, and in amongst those, of course, is MGD, and that's recognized as a conclusive risk factor, so one that we're definitely sure is involved in the dry eye process. And that's because it feeds into the vicious circle of dry eye disease. Meibomian gland dysfunction destabilizes the tears. That instability leads to excess evaporation, leads to hyperosmolarity. We get inflammation on the ocular surface, and then that damages the cells, and we start to see staining. And those abnormal cells then struggle to support a tear film, and we see the stability. And so we have that vicious circle. So MGD therapies can be in a number of different forms. Artificial tears is something that people tend to rush for, but we've got to be very careful there with MGD, because if you have a loss of the lipid layer, then really it's more the lipid supplements that you want to be looking for here. But other things you can do involve moisture retention spectacles to try and reduce the amount of evaporation. We have warm compresses. That's really the mainstay therapy for patients to apply themselves to try and warm the oils and get that released from the glands onto the surface. We also have devices such as latent heat devices, the blephostine, which heats the oils. But the ones I'm going to be talking about today are thermal pulsation and intense pulsed light as two of the kind of the newer in-office techniques that we use for managing meibomian gland dysfunction and whether or not they work. So beginning with vectored thermal pulsation, which is otherwise known as LipiFlow, it's the main device that's out there, the first one that came out. Now that's a device that is inserted underneath the eyelids so that we can heat the glands from beneath. So not heating from the outside like a warm compress, but from inside. And the benefit of that is that you have a vaulted area here to protect the ocular surface, and the heating element is on the outside edge here. There's the glands melting, and you have air bladders to compress the lids and allow the oils to be milked from the glands. And that's a single treatment. It's a single bilateral treatment. So both eyes treated at the same time, and the whole thing takes 12 minutes, and you should just need to do the one of them. It heats the glands to about 42.5 degrees, which is hotter than we can get with a warm compress, which is applied to the outside of the skin. Because by the time you make warm compresses very warm, you burn the skin, you risk burning the skin, or you risk the damage to the cornea. So this avoids that. And as I said, it expresses both the upper and the lower glands both at the same time. So is it effective? Well, some of the earlier research that came out said absolutely. It was working well at 9 months. So you could see differences in the symptoms, in gland function, and in the stability of the tears. And there have been, within this study, this original study that was started back in 2012, they've actually got longer term data coming from it to show that it might even be effective up to 3 years, as it is still from the single application. We see that with some of the questionnaires in the top left, we have the OSDI, the symptoms are starting to come back by 2 to 3 years after that single treatment. But with the speed questionnaire, the symptoms are still better. Tear film breakup time returns to normal probably after about 9 to 12 months, although meibomian gland secretion score seems to be maintained and possibly even increases over time. So there seem to be some good effects there. So how does it compare though to warm compresses, the standard or kind of standard of care? Well, Finis did an interesting experiment, a well-controlled trial comparing LipiFlow to twice daily lid warming plus massage. And at 1 and 3 months, symptomatically, patients were better in the LipiFlow group than the lid warming group. But actually across the rest of the parameters that were assessed, there wasn't a huge difference in the signs between the two groups. And so their conclusion was that the LipiFlow was at least as effective as warm compresses. Now, you might be sitting saying that's terrible, it should have been much better. But actually, we know that if patients do apply warm compresses properly, religiously, twice a day, every day for months, they will generally get a good effect from it. But of course, compliance is our biggest issue that we have with patients, and maintaining that is very difficult. So the benefit of the LipiFlow obviously is it's a one-off treatment, and the patients don't need to do anything else after that. There's also some work out more recently looking at contact lens comfort, and in an open label but randomized multi-center trial, they took soft contact lens wearers and randomized them to either LipiFlow treatment or no treatment, and found that in the LipiFlow group, they got much improved gland function, better signs and symptoms relative to the control group. And from a clinically useful perspective, they were able to increase comfortable lens wear by about 4 hours in the LipiFlow group, and that was about twice what the participants started with. And these effects were sustained for up to 3 months. The LipiFlow has also been compared to doxycycline as an alternative. That's something we tend to use as an antibiotic that's used for its anti-inflammatory properties. And in this study, again, it was found that the LipiFlow was at least as effective as doxycycline in improving gland function. And so probably the take-home message from that is, if you have a patient who doesn't cope well with doxycycline, because obviously it does have some side effects and some contraindications, then you may get with this lower risk profile just as good results using LipiFlow, a single treatment of LipiFlow. More recently than the LipiFlow, we have the iLux device out, and that's now from Alcon. And that's a handheld device, so it's much smaller than the LipiFlow. It's held by the practitioner. It's internally heating the glands. So there's this little part here is inserted underneath the eyelid, and heat is applied, as you can see over on the right-hand side here. The practitioner is pressing the button and applying the heat. That can be controlled. You choose a different temperature depending on how you feel what the patient can cope with and how bad their disease is. And while you're doing that, you can actually see through a little window. There's a magnifying glass, and you can see the lid, and you can use, you can compress the lid in order to express the glands once the oils have started to melt. And hopefully you can see that on the screen a little bit there. And then that covers about half the lid. So you would tend to need to do it twice on the bottom lid, and then you can flip it over upside down and do the same thing as you see on the right-hand side here for the top lid. So you would need to do 4 for each eye, and then obviously do each eye separately. So it's more time consuming, but less expensive than the LipiFlow. And that's recently been shown to be comparable in terms of the effect that you see for signs and symptoms in MGD. There was no difference between the devices, at least at 1 month. So it's relatively short-term data that's out at the moment, but we'll be looking to see how that pans out over time. The other thing I was going to talk about today is intense pulse light therapy, which is something I've been involved with for a number of years. Intense pulse light is not a laser. People tend to get confused. It's broad spectrum light, 580 to 1200 nanometers. And it was introduced, or we learned about it more from the cosmetic industry. A lot of work has been done there. But it was discovered by TFOS that it was effective for ocular rosacea in patients with systemic rosacea. And so we were lucky to be one of the first groups to look at the IPL in a randomized controlled trial. Now, it was a small trial, it was a pilot trial, 28 people, and we looked at randomizing the right or the left eye to treatment. We did a sham treatment in the other eye so that participants didn't know which eye had been treated. There were no confounding treatments, so we didn't do meibomian gland expression, even though clinically I would, to try and get the best effect I can. In this case, I wanted a scientific trial that was going to let me know whether the IPL itself was doing anything. And so there was no meibomian gland expression, no therapeutic expression performed in parallel with this in this trial. And the treatments were assessed on days 1, 15, and 45. And we found that the lipid layer improved in the treated eye only, and it got better over time. The stability improved similarly, treated eye only, and improved with time. And the symptoms we found improved more in the treated eye than they did in the control eye, such that 86% of participants reported reduced symptoms by the end of the trial. Since that time, there's been a lot of work published in the area on IPL, and the results overall have been fairly positive: improved clinical signs and symptoms, decreased inflammatory markers, and improved tear composition. But it's not all as easy as that, because of the studies that are published, there's actually quite a lot of limitations with them. There is a high risk of bias in a number of them, the way in which they're funded, the way in which they've been performed, whether they're open label rather than fully masked, whether there are confounding variables such as meibomian gland expression. And so you take all these results together, and if you actually look at them really carefully, as the Laura Downey's group did in Australia, and publish it as a Cochrane review, you discover that actually, in terms of what we know, IPL safety and efficacy is a little more uncertain than we might believe due to the lack of high quality studies. But all is not lost, because we, before that had even come out, we had also recognized this and had begun doing another study. And this is the work of my PhD student, Ali Zhu, who performed this study. And we did a better study with a larger sample size. We had 87 subjects in this one, a longer time course. And this time we did 4 treatments instead of 3 treatments. By then we decided actually doing 4 treatments, we could potentially get a better effect. The measurements were collected at the subsequent visit, and so it wasn't an immediate effect we were observing, it was the effect after a month of treatment, a month after the treatment had been performed. In this case, it was a parallel group study rather than a paired eye study, so the participants either received treatments to both eyes or didn't receive treatments to both eyes. So we had a very effective sham treatment in this case, and again, we didn't have any confounding variables with expression. And we also added in an arm which allowed us to compare 4 or 5 flashes to decide whether that increasing the number of flashes would make a difference. So this is where we applied the flashes. Conventionally, this is under the, there's goggles that are used to protect the globe during treatment, and the treatments are applied 1, 2, 3, 4, and the additional one with or without that in this study as number 5. We looked at a massive number of parameters grouped together. We can, these are as symptoms, tear film characteristics, some eyelid characteristics. We looked for Demodex, we looked at gland function, ocular surface staining, gland morphology, nerve function, nerve characteristics and other features from in vivo confocal microscopy. We did microbiology, and we looked at molecular markers as well. And I'm not going to report on them all in this short period of time. So the symptoms that we used were the OSDI, SPEED, and SANDI questionnaires to look at the patient-reported outcomes. And we used a wide range of diagnostic tools, clinical diagnostic tools, in order to perform our clinical evaluation and observe these metrics. So I'm only going to report, as I said, on the significant findings that we found. So symptoms, we found that the treated eyes were much superior in terms of their symptoms compared to the control eye. For the OSDI, that was showing up as early as day 15, but for all the different questionnaires we used by days 75 and 105, there were significant differences. And it was a little earlier in the 5 flash group than it was in the 4 flash group. The lipid layer also improved, again, only in the treated group, and that was at day 45 in the 5 flash group and a little later in the 4 flash group. By days 75 and 105, so that's our last kind of 2 and 3 months, we saw differences in both groups. Meibomian gland capping, the blocking of the glands on the surface, also improved, so that there was less capping by day 45 in the 5 flash group, and by day 105 that showed up with both groups. And finally, the bacterial load also changed. We saw some differences there with a reduction in some species of bacteria by day 105, both in the 4 and the 5 flash group. So from this study, it shows, this has given us, to date, it's been the most conclusive support that IPL, and specifically IRPL, because we use the EI, and there are a number of different devices out there. So we seem to get similar results, but obviously I can't comment on the other devices I haven't used. So for intense regulated pulse light, which is what the R stands for, we're seeing benefits, conclusive benefits in patients with MGD, even without meibomian gland expression. So we expect it to be even better if you did do gland expression potentially. We see reduced capping and that resultant meibomian gland improvement in the meibomian gland function that we see from having a thicker lipid layer suggests that we're unblocking the glands, and that's occurring not as an immediate treatment effect because of heat, but something that's happening over time, and we still need a lot of work to go into understanding the mechanisms of action here. We got significant effects observed after a course of 4 treatments, either with 4 or with 5 flashes, but the results appeared more quickly with the 5 flashes. We didn't reach a higher peak, but we did get the results a little more quickly with 5 flashes. So I think probably that's worth doing for patients who would like an immediate response to any treatment we give them. The sooner the better. So in conclusion, if we are hoping to get sustained results in treating patients with meibomian gland dysfunction, patients with dry eye, we need to treat the problem at the source. So before you rush in with lubricants, before you rush in automatically with anti-inflammatories, please think of the lids first and try and treat the meibomian gland dysfunction, because those other aspects will likely fix themselves. I think we should be embracing the expanding range of treatments or treatment options we have for meibomian gland dysfunction, but be careful to use the scientific literature to, for evidence, to make sure that we're informing our clinical practice from the scientific evidence base. Thank you very much for your attention.
Thank you, Jennifer. Wonderful talk, and I'm so glad to see some real data on IPL, and thank you for your wonderful study that really provided us many more information regarding these new devices. So I think we guys have a few minutes for discussion. Let's see, you received some questions from the people who are attending the webinar. So Victor, can you just see one of the questions that you want to discuss now about your topic?
Yeah, I mean, one of the main questions was the role and the use of cyclosporine, and correctly so, mentioned by some of the audience, of course, you know, in other more severe conditions of dry eye, specifically the autoimmune ones, higher concentrations of cyclosporine do work. In fact, you have to be patient. We want a quick fix. Some of these chronic dry eye patients, you know, will take some time to get effect of these immunomodulatory therapies. So either higher concentrations or more frequent is certainly indicated. And yeah, of course, they're not tolerated in some patients, so they have to be patient. And my reply was that, yes, I do like the use of higher concentrations. You can combine them with pulse therapy steroids to have patients tolerate them better. But I think the market is opening, and there are new assets coming where, you know, cyclosporine and other anti-immunomodulatory therapies will be able to be dissolved in better friendly use vehicles, if you will, and be more friendly.
Just to get a hook, do you have an experience with tacrolimus? Tacrolimus is used in Japan, is approved for commercial use in Japan. Here in Brazil, we have a paper that was published with the use of tacrolimus, which is more potent than cyclosporine and works in much faster. So do you have an experience in the US or in your center, or have you heard about the use of tacrolimus?
Yeah, I mentioned in my talk, you know, it's my go-to T-cell inhibitor either before or after cyclosporine. We have more experience in 2 conditions, especially in atopy It works very well in the patients with either verinal or atopic keratoconjunctivitis. We don't have a formulation in the United States. We use the dermatological preparations and ointment. As you mentioned, in Japan, it's being formulated. And I've been trying to welcome pharmaceutical companies to start putting this in a commercial available fashion, because you're right, I don't know if it's more potent. I think that it works with a different mechanism of action that for some other form of T-cell mediated diseases might be better. Certainly, it's in our experience, it's more tolerated than cyclosporine. But again, we have to compound it ourselves. We don't have a product that it's commercially available, as you mentioned.
Jose, we have experience in Spain with the tacrolimus, and the tacrolimus is using galenic formulations, 0.03.
Yes.
This product is FK506 and it's 10-fold more potent than cyclosporine at 1%. So 0.03 is 10 times more potent than cyclosporine 0.1%. So that means that we have a very potent product. It is very well tolerated, let me tell you. It's tolerated in over 90% of the patients, so it's quite good. And it's used once a day. And as it is a lubricant, it's very convenient because it's not making any discomfort to the patient. As a lubricant at night is quite welcome by the patients. And believe me, our experience has been very good. We don't have any study because we canceled the use of cyclosporine when we start using FK506, which is a calcineurin inhibitor as well. And believe me, this product has, in my opinion, an important future, but there is no company at this moment, in my opinion, investigating other than Japan, the commercial use of this product. But we use it in routine cases of dry eye and in the possibility of penetrating corneal grafts.
Yeah, that's our experience as well. We have some problems with a few patients in terms of feeling a little pain and discomfort with tacrolimus, more than we use it to see with cyclosporine. But maybe changing the formulation, decreasing the concentration, you can get a very good result. So I think it's very promising. Have you used in New Zealand tacrolimus for dry eye?
Yeah, we do. We do use that, absolutely. Yeah, I found it quite successful, and especially in patients who seem to have a kind of combined allergy and dry eye. It seems to work quite well in them.
Okay. Victor, just for you three, we have a question about omega-3. So especially for Victor, can you just comment your impression? Do you routinely prescribe omega-3 products for your dry eye patients? What do you think about not only the effect on the lipid composition, but also the anti-inflammatory effect of omega-3 orally?
Yeah, I mean, the data of the anti-inflammatory therapy doesn't come from the eye world, comes from systemic therapies. And again, it's like Jen was mentioning, you have to be careful where you get the data from, and real randomized prospective mass trials really have not been done from that point of view of anti-inflammatory capacity. Certainly we know of the DREAM study in the eye for meibomian gland dysfunction didn't show any difference from vehicle, but vehicle was oil as well. So the jury's still out there, but I do use it. A lot of patients already come using it. Certainly it's been used for cardiovascular disease, more joint disease, and certainly there's biology behind the different formulations and the role anti-inflammatory. But again, in the clinical setup, really it's not been a well documented effect.
Okay. Jorge, Jenny, any comments about the omega-3?
We use on routinary basis. That the evidence is not that strong. We use DHA as a basis, even pure DHA. But I believe that it's doing something, but I don't have a strong conviction that it's a definite treatment. In my opinion, it's something that helps in a collateral way to other measures. Only by itself is not that much the solution, And you know that meta-analysis about the use of omega-3 have been inconsistent. Doesn't mean that it's doing nothing, but it does mean that it's not one of the key factor for the treatment of dry eye.
Okay.
And I would say, can I just say something about, so recently there was a Cochrane report published on omega-3. So this is subsequent to the DREAM study, because obviously we had evidence that suggested it did work, and then we had the DREAM study that suggests it doesn't work, or doesn't work better than placebo. And the Cochrane report has come out saying there probably is something in it, but we need a lot more work. So yeah, I'm looking forward to seeing more work in the future to decide more definitively exactly what we should do, the length of time we need to do over, and the dosage that we need, the most appropriate dosage.
Okay. A question here for Jorge about the PRP. Can it increase neovascularization of the cornea or no? Comparing to the serum. Also about contamination, all the blood derivatives, they're more prone to contamination. Do you add any antibiotics or preservative when you have like an epithelial defect or the epithelium is open, in cases in which you identify risk factors for keratitis, microbial keratitis?
Well, first of all, what you should expect from the use of PRP is healing, and healing involves new vessels. Obviously, yes, it increases new vessels because it is part of the wound healing. When you are using PRP, you don't care about the vessels, you care about the dormant ulcer or something that you have to treat, and in the healing process, the vessels are attracted, and you have anti-inflammatory cytokines, but pro-neovascular cytokines as well. Second, contamination is that rare that we have never had a problem, you know. I mean, about 2,000 samples already in cases in our patients, not a single contamination. All the hemoderivatives have antiseptic conditions if you don't add anything. So basically, you keep in a neutral environment and you work in a closed system or almost closed. It is very difficult to contaminate, and definitely the product keeps the sterility by itself. The third is we don't use antibiotics when using PRP unless we have a corneal ulcer. If there is a corneal ulcer, we use, depending on the type, different models. The main one is moxifloxacin, a couple of drops a day maximum in order to prevent infection. But this is because we use it in every corneal ulcer, not only with PRP. But if we use PRP in dry eye, we don't use any antibiotic. And finally, about the contamination potential is very minimal. We use these bottles for a total of 6 weeks, and these patients have had at the beginning microbiological controls in order to ascertain whether we had any potential for contamination. Uniformly, all of them have been always negative. So I can tell you that it's a very safe product as far as the manipulation of the patient is appropriate, and it's a healing product. So what you have to expect is improvement in the healing process as a whole.
Thank you. I have a last question for Jennifer. Jenny, we saw by your study, the last study you published about the IPL, that 5 pulses with DI devices better than 4 pulses. At least you can get results earlier. My question is, some of the devices you can also apply in the superior eyelid. What's your thought about doing in the superior eyelid? Do you think you can get maybe an extra result, or the way that intense pulse light work, you don't need to do this superior eyelid?
It's a good question, and I don't have a definitive answer for you. It would need to be tested properly, and it hasn't been to date. What I would say is that when the goggle is on the eye and the eyes are closed, the bottom of the top lid is actually very, very close to the top of the bottom lid. They're actually right next to each other. So whether you do need to have, I mean, we don't know the mechanism of action, and I'm actually halfway through trying to answer a mechanism of action question that I've been asked just now. We don't know the mechanism of action, and until we're very clear on that, I don't think it relies on direct application. So if that's the case, then it may be that we won't get an improvement from the doing it on the upper lid. But I know some people do put in a haptic, like a haptic lens, like a haptic contact lens, a scleral lens, but metal, so that it protects the globe, and then they can treat the top lid. So I know some people do that, but I don't personally.
And do you think you can combine the thermal pulsation or thermic therapy with the IPL for the cases you can maybe have a negative effect in these patients?
It may well do. Again, we don't have evidence to say otherwise. It's an expensive exercise, I guess, for patients doing both. Whether you would expect to get, I mean, there's slightly different mechanisms for the similar kind of hope. The intention, the outcome that you're looking for is similar, but they do something different. So I have in some patients tried to do both. I've tended to find those in whom it doesn't work for one, it tends not to work for the other. So they may just be the more intractable cases, possibly with some neuropathic pain element, as well as the MGD.
Okay, thank you so much, guys. So we have a few questions that are coming to the chat, and please, I ask you, the speakers, to answer those questions, and we can move to the second part of the program with the surgeries. And so for that, I'm going to pass for my co-moderator, Jose Vargas. Jose, are you in?
Yes, I am. The moderator now is Dr. Osorio. He's a senior consultant at King Khaled Hospital. So he will be moderating the second part of the symposium.
Okay, thank you, Dr. Vargas. So we're going to move to the second part of the symposium, that is the surgical treatment of the ocular surface disease. The first talk is about the surgical treatment for severe dry eye. The speaker is Dr. Jose Gomez, who is a professor of ophthalmology, director of the Master in Ophthalmology and Visual Science Program, director of Corneal Transplantation Residency Program, director of the Advanced Ocular Surface Center in the Department of Ophthalmology and Visual Science of the Federal University of Sao Paulo in Brazil. Please, Dr. Gomez, go ahead.
Thank you, Hernan. Thank you, Jose. Thank you to my colleagues. And let me share the screen here. So can you see the PowerPoint? Is that okay?
Yes, it's perfect.
Okay, thank you. So the topic now is surgery for dry eye. And this is my financial disclosures. As we know, dry eye is a multifactorial disease that represents a wide spectrum of ocular surface alterations, from the mild cases to the moderate cases and to the very severe cases with also keratinization of the ocular surface. The dry eye treatment, according to the TFOS deals, also need to follow this spectrum, starting from level 1 cases with more clinical and medical treatment, to level 2, level 3 with the introduction of immunomodulators, autologous serum and other hemoderivates, punctal occlusion, and finally to level 4, we need to consider some more invasive surgical approaches. And for us to choose a surgical approach for a very severe case of dry eye, we need to understand the concept about the ocular surface and lacrimal function. And we know that it works as a unit composed by the ocular surface epithelium, innervation, and the glands, the lacrimal glands. And this is very and extremely important to maintain the homeostasis of the ocular surface and the survival of the transparent epithelium of the cornea. We also know the importance of the lacrimal pathway. So when you consider surgery, we need to start thinking about some strategies to try to preserve more tear in the ocular surface. And for this, you can think about the occlusion of the punctal and canaliculae, and this can be achieved with plugs, with thermical, and we know the plugs are the most common way and more popular way to occlude the punctum. But we also know that we have complications with the introduction of plugs in the lacrimal punctum: extrusion, granuloma, migration, and also you can have infection. So for patients who have problems with the plugs and you want to occlude the punctum, you can use surgery. And actually it's a very elegant way to use a small conjunctival flap or even oral mucosal flap to occlude the punctum. And this is good because you don't have the complications of the plugs, and you can also have a reversible surgery. You can easily, if in case of the need to reopen it, you can do it through the mucosal flap, either from the conjunctiva or the oral mucosa. The other surgery that is very important is tarsorrhaphy. This is a very classical way to treat severe cases of dry eye. So by decreasing the exposure area of the ocular surface, and actually if you do medial tarsorrhaphy, you can also get the opportunity to occlude the lacrimal punctus. So we know that tarsorrhaphy, we have different types: temporary, permanent. You can do partial or total in the very severe cases in which you want to close the whole surface of the eye. And the way that it acts is decreasing the exposure area of the cornea and conjunctiva. So we also have the opportunity to correct the lid's position by doing this procedure. The third way to surgically work in dry eye cases is for cases in which the patient have problems to occlude the lids. So in paralytic lagophthalmos, you can use, for instance, the implantation of upper eyelid implants like the golden ones that you can help the patient to occlude the eye, in this case of paralytic lagophthalmos. You can also use other oculoplastic procedures by the using of a spacer, either by cartilage or porous polyethylene and others, to work especially in the inferior eyelid, so we can improve the situation of lagophthalmos. For cases in which you have problems of the conjunctiva, maybe one that really disturbs the homeostasis of the ocular surface is symblepharon. We know that we can use some procedures. One that is very popular is the use of amniotic membrane transplantation, which has not only the advantage to replace the area that you resect, the symblepharon area, but also providing some anti-inflammatory effect on the ocular surface. The problem of amniotic membrane transplantation is you have a very high rate of recurrency, especially in inflammation, in inflammatory conditions. So that's why sometimes you can use it, but you can add intraoperatively mitomycin C to decrease the recurrence cases. And actually, this is a case of ocular cicatricial pemphigoid, bilateral complete ankyloblepharon. And we have a very difficult situation, and this patient was firstly controlled systemically with immunosuppression because it's a systemic immune disease. And then we needed to work with the symblepharon, and we did a resection of the symblepharon. And because the oral mucosa was very bad, we then decided to use amniotic membrane together with intraoperative use of mitomycin. And we also, in these cases of severe symblepharon, it's important to use a symblepharon lens. that the patient needs to use for a couple of weeks, and we get a very nice result in a bilateral case of symblepharon and ocular cicatricial pemphigoid using a amniotic membrane together with mitomycin C. But of course, the best treatment for severe symblepharon, especially the lesions that are very inflammatory, are the use of the oral mucosa. When you can use, it's the best, it's the ideal situation. And actually you can get a very thin layer of the oral mucosa using mucotum or other strategy. And this can be very useful for these cases. We know that the oral mucosa is a little bit different than the conjunctival mucosa. And nowadays, with the use of tissue engineering strategies, with the ex vivo cultivation, we can get a very nice epithelium of this oral mucosa cultivated ex vivo that can be very similar to the corneal epithelium. And actually, with the cultivation of the oral mucosa, we can get a very nice sheet of new autologous epithelium that can be used for reconstructing the ocular surface, thinking about restoring vision in these patients. And this is a very nice strategy that has been used in Japan for many years. So it's not only a good way to treat symblepharon, but you can cover the cornea with this cultivated oral mucosal epithelium, and you can also treat the vision problems or the corneal surface opacification. We tried to do this procedure in Escola Paulista. We had a couple of cases. The only problem is that you can have a lot of problems with the new vascularization of the cornea. But of course, it's a very nice way to deal not only with symblepharon, but also with the corneal problems in the very severe cases. You can also use the nasal mucosa for symblepharon, and that you gain an advantage. The nasal mucosal tissue is full of goblet cells, which you don't find in the oral mucosa. So we can get even a burst or a better effect in the mucin layer of the tear film by using the nasal mucosa. The only problem is that it's difficult to obtain, is little thicker, but you can even combine with the oral mucosa for the treatment of severe cases of symblepharon and dry eye. So this is one of our cases in which we use the nasal mucosa. We placed it in the inferior fornix, and we got a very nice improvement of the dryness of this severe case of dry eye. The other strategy to treat extreme severe dry eyes is to use the salivary gland transplantations. And this is a not new procedure, but you can use the saliva, which has some similarities with the tears, to provide lubrication of these very severe cases. You have some differences, but we have some similarities, especially concerning some of the protectants that you find in the tears that you also have in the saliva, as the IgA and others. The first procedures started in the 50s with the parotid gland transplantation by the Russians, and then the Spanish school, especially from Dr. Murubi, he started with the introduction of the submandibular gland transplantation, and which is a very nice procedure. This is a paper that was published in Ophthalmology in '98. It's a classic paper by Gerd Gerling in Germany, which found a very nice result improving Schirmer in different severe cases of dry eye, as ocular pemphigoid, chemical injury, and Steven Johnson's, with very good results in terms of improving Schirmer from 1 to 15, and some of these patients even develop increased tear or epiphora, which is a side effect of the submandibular gland transplantation. The problem with the submandibular gland transplantation is sometimes infections or problems with the duct that you need to connect to the surface of the eye. So you not only have epiphora problems, but but sometimes problems of infection. The other procedure, which is a very nice procedure, is the minor salivary gland transplantation. So in the oral mucosa, you can have this minor salivary glands, which can be transplanted in block to the superior and inferior fornix. And with this procedure proposed by Murubi, we made some changes, some adaptations, and we started to use for all of our Steven Johnson's cases. This was part of doctor thesis of Dr. Anistela Santana, who is an excellent oculoplastic surgeon, and this was presented at the American Academy and published in BJO in 2011. So the first cases we did in 19 eyes of Stevens Johnson's, and the adaptation that we made was that we started to remove a very thin layer of the oral mucosa with a mucotomy before getting the glands. And this layer of mucosa we used to correct the symblepharon. And it was interesting that after we started doing this removal, we are starting to observe better results, maybe because the surface is scarred and the glands are in the submucosa, so we open the glands. So after we remove this thin layer of the mucosa, you can get the submucosa with all the glands. See, you can hear the small balls here are the units of glands. And usually when you identify more than 10 of the small glands, you get better results. And most of the Steven Johnson's patients, they have the glands preserved. And it was a very interesting finding. And that's why we started to observe good results. So with the oral mucosa, we will correct the symblepharon that many of these patients have. And here you put in the inferior and superior fornix, you open a space medially or nasally, and then you insert this glands, this complex of the glands and submucosa, and then you close the oral mucosa, and you can put also a symblepharon lens. And this is a short video showing the procedure. So we can see here this very severe case of Steven Johnson's complete ankyloblepharon. So we open, we can get the thin layer of mucosa. This is an important step in our hands. The second is, so you open the submucosa, get the glands. So you have, then sometimes you need more oral mucosa because the ankyloblepharon was very extensive. And then you open a space in the fornix, put the glands, and you make a suture of 4O silk through the lid to fix the glands in the place, and then symblepharon lens. So with this procedure, we got an improvement of 70% of the eyes or more in terms of lubrication. All eyes had an ocular surface improvement in terms of transparency, neovascularization, symptoms. And we also observed that a few of these patients had improvement in the vision after having this procedure, even without touching the cornea. Here you can see that the improvement in the Schirmer's with the minor salivary gland transplantation is not that great as the submandibular gland. So it goes from 0 to 3 to 1 to 1.5, but you improve a lot the condition without having the problems of epiphora. And here you can see a very interesting case, pre-op and post-op. You can see here that the keratinization was just dissolved after you improve the lubrification of the eye with the minor salivary gland transplantation. This is another eye, pre and post, so many of these patients improve a lot the condition. It is interesting that some of these patients we needed to have oculoplastic surgery after a few years, and we get a biopsy of the site where we implanted the glands, and the glands were there. Actually, we published a paper in Cornea 2 years ago in which we show that the glands are there, the tissue are there, even 2 or 3 years after the procedure, showing that the glands are still functioning after a few years of the minor salivary gland transplantation. So what about visual rehabilitation in these very severe eyes? We know that we need to do many times ocular surface reconstruction with different kind of limbo transplantations, even corneal transplantations. But we know by some survival analysis of all these ocular surface procedures that the main risk factor for failure in a multifactorial analysis is the severity of dry eye. So before we started doing the salivary gland transplantation, we had patients with shimmer of zero prognosis before 1 year after limbo transplantation. And so that's why after we saw these results, we started to make a very nice stepwise management of these very severe cases, always starting with the lids abnormalities. Then if the patient has very severe dry eye, especially cicatricial diseases, we do the salivary gland transplantation. And then we go for the management of the limbo stem cell deficiency and corneal opacification. And after that, we moved from 0 to 25 or 40% of good results. This is just an example of patient with Stevens-Johnson's that had a complete ankyloblepharon, multiple surgeries, and we started doing salivary gland transplantation, limbo conjunctival transplantation. So you can see here after the salivary gland transplantation and limbo transplantation, you can have a very good scenario for an ocular surface transplantation because you have tears, you have limbo stem cells, and then you can move to the corneal transplantation, tarsorrhaphy. And this patient is after 4 years, she's still doing very well in terms of vision. When nothing works, we know that we have the option to use K-pros, and K-pros are a very good way to treat this eye, but we also know the problems with K-pros, especially complications like glaucoma and retina problems. The most common used K-pro is Boston K-pro type 1, and we know that the Boston K-pro type 1 is not a good indication for eyes that are very severe dry eye, like Stevens-Johnson's eye. So that's why we and other groups actually are putting these cases together. We are getting eyes of Stevens-Johnson's that are very controlled in terms of inflammation. We are performing salivary gland transplantation, correction of symblepharon, and then we indicate K-pro type 1. So for few of these patients that have the inflammation controlled, we are getting very good results with the K-pro in these cases. So it can be used after salivary gland transplantation, K-pro type 1 in a very few selective cases. The other options for severe dry eye is Boston K-pro type 2 through the lids, and also the osteodontal and osteo K-pro. Finally, the other very interesting surgical procedure involves the establishment of human lacrimal gland cultures. So with cell therapy, you can even produce lacrimal gland in the lab, and then you can transplant this bioengineered lacrimal gland. And this has been done in animal models showing very promising results. In conclusion, treatment of dry eye includes different modalities of surgical procedures. This is for severe dry eye that involves the lids, conjunctiva, and other mucosas. And indicated when conventional treatment fails to maintain appropriate lubrication of the ocular surface. The salivary gland transplantation in our hands is definitely included as an alternative option and can be very useful to prepare the eye for ocular surface reconstruction, especially in the severe secret tissue diseases. New perspectives, including cell therapy, are under investigation. So I want to thank you and pass the word to the moderator.
Thank you, Dr. Gomez. Our next speaker is Dr. Virinder Sangwan. He will talk about the limbal stem cell deficiency treatment with SLED or not SLED. Dr. Sangwan is the Director of Innovation of the Dr. Shroff Charity Eye Hospital. He's the Director of the Clinical Trial Center, Associate Director of the LB Prasad Eye Institute, and also Head of Cornea and Tissue Segment, Head of Ocular Immunology Service in the same institute, and Associate Professor in the Case Western Reserve University School of Medicine, and in the School of Medicine and Dentistry of the University of Rochester Medical Center. Welcome, Dr. Sangwan, and thank you for accepting the invitation. And please go ahead.
Thank you very much for the kind invitation. I'm going to talk about simple limbal epithelial transplant. Another procedure. I have no financial disclosure to make relevant to this presentation. This is one of my patients whom I treated in 2001 with a unilateral stem cell deficiency due to chemical burn. She underwent a cultivated limbal epithelial transplantation in 2001, followed by a penetrating keratoplasty. Almost now 19-20 years follow-up, she still maintains 20/25 vision in that eye and doing very well. Then we switched to a technique called simple limbal epithelial transplantation, and we performed that procedure in this 9-year-old boy who had chemical burn with granuloma and total limbal stem cell deficiency. You can make out from here, from the pre-op picture and the 6 weeks post SLED, cornea cleared very nicely, except there was a superior symbliphron, and the histopathology of the penis showed a profound inflammation. Then he underwent a top-up SLED or a touch-up SLED with conjunctival limbal autograft, and this picture here shows very nice clearing with a best corrected vision of 20/40. So we've been doing the cultivated limbal epithelial transplantation or ex vivo expansion of limbal epithelial stem cells in the lab in LV Prasad from 1999-2000 onwards, and clinical transplantation from 2001. We have developed our own technique of submerged explant culture with no 3T3 fibroblast, no airlifting, and no fetal calf serum. In 10 to 14 days, you get enough cells to transplant, and the surgery what you just saw. Over the years, for 10 years, we published extensively on this topic in various journals with excellent outcomes, and also published a paper in JAMA Ophthalmology in 2013, showing that in pediatric limbal stem cell deficiency, this technique of cultivated limbal epithelial transplant does not really work very well. The best success rate we had was 40%. And remember, we had a lot of patients with amblyopia because you have to wait for a long time to do the CLED. Then there are some other drawbacks, which consist of for ex vivo expansion, you need to have an expensive laboratory to maintain. The patient have to come twice, first for the biopsy and second time for the surgery. So there is a cost and there is a waiting period. And also there is some chance of infection or contamination of these cultures, either in the lab or during transportation. And as I said earlier, in pediatric LSCD, it doesn't work as good as in adult limbal stem cell deficiency. In this paper by Alex Short and Julie Daniels from Moorfield in survey, they also pointed out that about 20% of primary explant cultures may fail due to infection or other reasons to take the biopsy again. So to overcome these problems, we started developing another procedure of growing the cells on the surface of the eye using the eye as a petri dish. And this surgery we named as simple limbal epithelial transplantation. And the short video you are just seeing here, this is a mild kind of limbal stem cell deficiency. You clear it, all the pannus, and then use the fibrin glue all over the surface and stick the amniotic membrane on top of that, trim the excess membrane, and then cut the limbal pieces which you have harvested from the other eye, as shown here on the back of the Teflon block. So make 8 to 10 pieces, and you can use scissors, you can use a 15 number blade, and then put these explants on the surface of the cornea. I would not put the glue first put the explants, arrange them nicely equidistant at the mid periphery of the cornea, and then put the fibrin glue, wait for a minute, and then you can put the bandage contact lens. Most patients would not need a tarsorrhaphy, but in severe cases or where we think the contact lens may not stay, you can use tarsorrhaphy. This is a procedure for the autologous slat. If you are doing an allo slat, then you need systemic immunosuppression, and the rest of the procedure remains the same. You can see the outcome. This is a pre-op and post-op of 6 weeks later of another patient. This is a patient with 1 year follow-up before and after. This is 2 year follow-up before and after. And this is 3 year follow-up. And now we have patients who have completed 5, 6, 7 year follow-up. And I'm sure my colleagues from LVP will publish 5 year or more follow-up of these patients sometime soon. Also, SLAT is not just for limbal stem cell deficiency. There are other unique applications, and every day there are new applications developed somewhere or other. There is a clearing effect on the stromal scarring, and which I believe is because of the mesenchymal stem cells in the limbal explants. It is used for pediatrics, LSCD much better, much higher success rate. Alloslat, cadaveric have been used in acute chemical burns and shown very good results. Mini slat for pterygia, for recurrent pterygia from Canada, primary slat for OSSN, and then variety of modifications. I also have seen some publication recently of slat being used for persistent epithelial defect. Here is one of my patients where you see in July 2011, he has a unilateral LSCD with counting finger PL positive vision, undergoes a slat, and a month later has some scarring left, but cornea seems to be clearing. And you see another year, 6 months later, improves further. Another year later. So eventually, he didn't want any DALC or PK, and he develops 20/40 vision. What does it mean? It just simply probably means that there is something more in these explants than just the epithelium growing from those explants. And what we believe now is this is an observation we published in 2007 and 2008 of presence of the stromal mesenchymal cells in the same biopsies when we were growing. And we published these 2 papers in Molecular Vision and IOVS characterizing these cells. And then we started thinking, can they be used for ocular surface reconstruction or for stromal scarring? To do this work, Sayan Basu from our group went to Pittsburgh at James Fundenberg's lab, and where they shown that this is possible in a mice model of corneal scarring, that this scarring clears with the mesenchymal cells. Independently of our work, a group from Harvard Medical School led by Sunil Chauhan showed that the mesenchymal cells have a beneficial effect and restore transparency of the cornea in an acute burn model of the mice. And then they worked out that it is the HGF, this is the hepatocyte growth factor, which is restoring transparency. It's a very nice work published in several papers. This is one of the clinical application in an acute sort of toxic keratitis in both eyes, and mesenchymal cells mixed with fibrin glue were applied and the cornea clears over a period of time. And now we have been using this study under protocol for a variety of different conditions. This is an example of an OSSN combining primary OSSN excision with slat. If the OSSN is 2 or 3 cloaca hours or less, you don't need any additional procedure. If it is more than that, you would need any adjunct therapy. Otherwise, you will definitely get limbal stem cell deficiency, like in case 2. And now this has been extensively published from LVP by my colleague, Dr. Swati Kalki of Ocular Oncologist in OSSN, and this was published in AJO 2017. Then a paper by Dr. Vikas Mittal in pediatric LSCD, excellent outcome of slat in these kids. This is a patient, a boy, 2-year-old with a toilet cleaner injury in one eye, underwent amniotic membrane, and in the acute phase, he underwent a slat, and within 6 weeks, you see the cornea cleared and he develops 20/40 vision. Subsequent to that, we published a paper in ophthalmology of 125 eyes, post-ocular burn, both pediatric as well as adult. And these were these criteria for success and failure of the slat. In this, one of the graphs in the paper shows the success rate of slat in adults and children is exactly same and very close. And long-term survival also seems to be good in both. Visual acuity 2-line or more improved in more than 70% of kids and adults. Also in some patient who underwent PK, we did immunofluorescence to demonstrate the markers of the limbal stem cells in post-slat corneas, which shows the corneal phenotype. Then there are some independent studies replicating the technique. This is Dr. Vikas Mittal's group. This is an international group, multi-center collation of results from different countries and different cities within India, and showing exactly the same results what we showed. Therefore, sort of reconfirming that what we are doing, others can replicate. Then there are some modifications of the technique by different surgeons around the world. Now, when I reviewed the data recently, we were writing a paper on the economic benefits of slat with a group in Sheffield. Till date, there are 441 patients reported in the literature, in peer-reviewed literature, who have received slat, and the studies are reported from 8 countries. More than 30 publications of simple limbal epithelial transplantation. These are original studies, and there are many more. However, in the last 5 to 7 years, there have been no original article on cultivated limbal epithelial transplantation. We have been doing workshops to train surgeons from around the world, and this is the graph of publication. On the left lower corner, on the right lower corner is the number of patients, which continues to grow. This is the comparison of CLAU, that is cultivated autologous limbal, conjunctival limbal autograft, CLAT, and the slat. From looking at this, whatever you do, whether you put the limbus, whole limbus, whether you do slat or CLAT, you can restore success in 70% or more. So what a surgeon need to decide is which technique gives you the best result with safety. And if you ask me, if you look at in different these parameters, the donor tissue size, donor eye safety, epithelialization pattern, success rate, visual outcome, affordability, repeatability. In all these 7 criteria, slats is either scores better or equal to other techniques. So cost effectively, I'll show you, these are some of the more comparison of the data, and mostly these are from India and Italy, because these are the 2 groups who have been very active in doing large numbers and publishing. If you look at the economic impact or the cost, the slat costs in India about $700 on an average. CLAT costs 7,000 rupees, 7,000 US dollar. And if you consider in Europe, there is a technique called Ocular, which is CLAT based. It is 85,000 euro. And I don't know how many people are doing it or which governments can or who can afford that expensive treatment. It's up to surgeons and the patient to decide about it. The why SLET is favorable, again, just to reiterate, it's a one-step quick procedure, can be easily taught, replicable, less expensive, no ex vivo expansion, so therefore no blood products. There's no risk of contamination. There's no culture-related risk, and second biopsy required is possible. And now we have long-term results, both CLET and SLET, and the outcomes are as good or better than the CLET. And there are many other applications. There can be modifications of the technique. So between these three techniques of CLOUD, CLET, and SLET, I think SLET seems to be clearly a technique which is preferred by most surgeons around the world. What is the mechanism of healing? If you look at this paper published, very nice paper in 2015 in Cornea, look at the explants, how the clearing happens around each explant, and exactly in about 10 to 14 days, you get a clearing, epithelialization, and at that stage, you can remove the bandage contact lens. And this is exactly what we observed in our cultures when we were growing the limbed cells in the lab. Exactly, there is a mirror image. So there is no difference of growing the cells in the eye or in the laboratory. If you grow in the eye, there are far more biological response. And here is some published results comparing the epithelialization rates or pattern in CLOUD and SLET. In CLOUD, there's only one direction from the cut as the epithelium can grow towards the cornea, and it may not be smooth or irregular, while in SLET, each explant gives rise concentric growth, so there is a multi-directional healing, and it heals much faster. How SLET might be working? My imagination is that SLET has these implants have growing cells all around in 360-day areas, mesenchymal cells and their variety of other cells, exosomes secreted by the mesenchymal cells, and the limbal implants, or explant, whatever we call them, they stay much longer on the surface in patients with SLET as opposed in CLET. And also, these implants or explants are like a mini limbus sitting there on the cornea and giving out the signals for further growth and maturation. And there's another study I saw quick of high definition ASOCT imaging the SLET. And for the sake of our understanding, it has been labeled nicely. And just follow these pictures over a period of time on day 5. Day 8, you can see the spreading and thinning of the explants. And on about day 11, you get further thinning. And by day 14, they will become quite mono layer. And in 6 weeks, it becomes stratified. In 6 months, you will not be able to make a distinction between the normal cornea and the epithelium post-SLET. So in summary, I think SLET is very effective, replicable, repeatable, affordable, and reliable, an open platform technology for treatment of limbal stem cell deficiency. And in my view, this is, it democratizes the technique. And it's not dependent on rich or poor countries or an institute which has the sophisticated laboratory versus those who don't have. And so there's really no comparison with other techniques. In my view, this is the technique which is likely to stand in the long run. Thank you very much.
Thank you, Dr. Samuel. You summarized your work in only 15 minutes. It was amazing. Our next speaker is Dr. Jose de la Cruz. Dr. Jose de la Cruz is Associate Professor of Ophthalmology at the University of Illinois Eye and Ear Infirmary. He's attending surgeon and cornea and refractive and surgery service and comprehensive ophthalmology service, and medical director of the Millennium Park Eye Center in Chicago, Illinois. He will talk about Boston keratoprosthesis and the PanCornea study. Welcome, Dr. de la Cruz. The microphone, please.
Thank you, Renan. It's a great pleasure to be among great friends and speakers. My job today is to discuss with all of you briefly keratoprosthesis, more so the PanCornea study which we've been working on for several years now. And we've got some updates and some new data, as well as some old data that I wanted to share with you. Can you all see the screen? You see it?
Yes.
Yeah, we can.
All right, perfect. So thank you very much for inviting me. It's a great pleasure. So as you'll know, and we're going to talk briefly about Boston K-Pro, and before we get to the data component, it's the most commonly used prosthetic device for visual rehabilitation in the world right now. As you all know, it's been developed by our good colleague and friend, Dr. Klaus Dohlmann. That was approved back in 1992. It's among the procedures now that are the choice for patients with poor prognosis for standard keratoplasty or after multiple failed transplantations. As I would briefly mention by Dr. Gomez, there's different prosthetic devices, the type 1 and type 2. The one we'll concentrate on is the type 1, which is the one that basically, as you see in the picture here, which is the type 2, which is a crossalid, which is more severe cases. But our conversation will be focused on the type 1 model today. Briefly here, as far as the assembly, I've given you sort of a collage of pictures here, which are 3 components, and then the donor tissue, which I also share with you a small video, how the assembly and implementation goes about. But briefly, as you see here, there's 3 components. There's the optic component, which carries the visual, the power of the K-Pro if it's necessary, and the aphakic model versus the pseudophakic model, which is the plano. And then the backplate component and the titanium locking ring. Now, there's different modifications to it recently, but just to keep the conversation simple, these are the 3 components that are used, and we use the donor tissue as a carrier. And as I'll show you here in the short video here, this is the assembly and the implantation of the actual prosthetic device. And again, the type 1 is the one we're using. So basically you use this is the optic component. We use a little sticky component to keep it stable in the OR. This is the donor tissue, which you can find it between 8 and 7.5 in diameter, depending on the pathology. And you have a 3mm trephination with a dermatological punch to thread it through the optical component of the front plate. This just a viscoelastic. In some cases, I use this just for having ease of the implantation of the back plate. And you see the back plate here in this case, I believe I'm using a 7mm back plate, but there are different choices of sizes between 7, 8.5, and even bigger ones in some cases. I make sure that's nice and snug, and I use a titanium locking ring, as you'll just see here, to basically lock it in place. And that's very important that you are sure that the ring is in place. Otherwise, we'll have a small gap, and then there'll be inappropriate assembly itself. I'll show you an example here of a incomplete assembly, and you'll see how there's perhaps a gap between the optic, as you see here, and the donor tissue. So in this particular case, you have to make sure then go back again and really push that titanium locking ring in place to assure that it's properly implanted. And you'll see here as I do that, I go back and I push in the titanium ring, and now it's in place, and it's adequately placed and without a gap between the tissue and the front plate itself. Implantation is basically like a standard implantation for a keratoprosthesis. I'm sorry, for a corneal transplant. This is the case in which we're going to incorporate the scar tissue at the same time. You go ahead and you mark your cornea, and the actual implantation goes ahead as before with the standard trephination. And I'll show you here. Basically, in these cases, you have to remember there's a lot of adhesions that might be in the cornea, so you want to be careful when you take that initial tissue. In this case, I'm using vitrectomy to really remove any adhesions to the actual tissue that we're removing. And if you have to do any type of reconstruction or removal of the anterior chamber, either iris or the components, so you have to be very careful so that you don't perhaps have any retinal tissue, any tissue that might cause tearing and damage the rest of your surgery. I want to point out in this particular case, I did not use a flaring ring, but I do recommend that you use a flaring ring when you have an eye that's aphakic, so that you can keep the eye form while you're actually doing the actual implantation of the keratoprosthesis itself. You see, we're doing a quick vitrectomy here, anterior vitrectomy, and then we go ahead and implant the device, as you see here, with standard suturing, interrupted sutures through the tissue that you use as a carrier itself, as you see here. So that part doesn't change very much from your standard procedure of a penetrating keratoplasty. So an example here of a pre-op UBM, and that's why I said when you remove these tissues prior to implanting the keratoplasty, it's very important that you examine or have evidence that there's no adhesions as you see on top here, because if I were to just remove this tissue and pull it out, that would cause damage to any other structures inside the eye. So be careful when you move these tissues prior to implanting the keratoprosthesis in this case. And just an OCT image, the ones that you haven't seen this before, how it's implanted and how somewhat crowded is the anterior chamber in these cases. Keep in mind that these eyes are the eyes that had multiple procedures, so there's a lot of scar tissue, perhaps the iris and the angle is closed. And you see here that the optic component, the back plate, and the shadowing, which shows you then that there's a titanium locking ring, since the OCT won't be able to image beyond the titanium tissue, titanium component that we have here. And just briefly, the phakic model, the only difference is basically the optic here has a power to it that it's related to the actual length of the patient versus the pseudophakic model, which is basically a plano model in the case that you're implanting or keeping an intraocular lens in the eye in some cases. So going back to what we wanted to do when we've done together with the PanCornea group and our Latin American colleagues that do keratoprosthesis, is that we wanted to look at the outcomes, because we sometimes see the outcomes of different regions, and perhaps they either correlate or don't correlate with the experiences that other patients, other surgeons in other regions are having. Therefore, with the collaboration of the PanCornea and the KPRO study group, we looked into incorporating and gathering all the information of all the surgeons in Latin America. And you see here, between 2005 and 2014, we have a decent group of surgeons, great surgeons that have been dedicated to KPRO surgery. And we have a significant amount of cases that were done in this region between 2005 and 2014. Now, I want to point out that we are doing an additional review, which goes all the way to 2018, which will give that information soon, but it correlates with the information that I'm providing you here today. So 6 countries, 9 surgeons. And then for the initial study, we looked at 227 eyes. And for the analysis, we focused on the PMMA backplate ones as opposed to the titanium backplates, but we're incorporating the 58 eyes in our next study also. So as far as the demographics, you see it's 110 patients that are male, 57 that are female, a mean age of 52 years old with a standard deviation of 19, and a mean follow, which is important here, of 38 months with a range between 1 month and 122 months. So a significant amount of time. As you all know, the ones that have done KPRO before, we usually have a dreamy period, a fantasy period for the first year, and then after that is when if we are going to see complications, they'll happen after the first year. So, keeping in line with the study suggested guidelines for the reporting keratoprosthesis by the different societies, we decided to do the diagnosis by non-inflammatory chemical injuries and autoimmune as directed by this paper in Cornea a couple of years ago. And most of the patients that we have here, non-inflammatory, 58% of the study that we looked at here. And as you know, significant improvement in vision. You have to keep in mind also that within this group, there are patients that are perhaps aniridic and so on. So their potential baseline potential of vision is limited. So therefore, it doesn't really reflect in the number itself in regards to improvement, but certainly improvement in regards to retention and improvement in visual acuity and functionality for these particular patients. As far as complications, we looked at specifically RPMs, melting, and infection, which is the ones that are more prominent here. We looked at glaucoma individually. We'll talk about briefly in this study. RPM were the most prevalent one with 38 cases, 27 of melting, and 8 infections, as we saw here. So going into a little bit more in detail as far as RPMs, I just want to just first give you a little overview of it for those of you who've not been necessarily looked at or understanding the RPMs. How do we evaluate these retroprosthetic membranes? Previously, you really couldn't evaluate them in a slit model when they showed up in front of the optic, and now with the use of OCT, we can actually see them as they grow prior to getting to the optic, and perhaps we can be more proactive in treating them or predicting what type of behavior they will cause in the implanted keratoprosthesis. Is an example here of a patient that was implanted over a period of time, a period of a year. You see how the patient does not have any retroprosthetic membrane. This is the optic, so you wouldn't see it unless you had an OCT. And over time, you see there's thickening here and progression as we go over time. before it even gets to the optic. So again, RPMs are something that happens prior to us seeing it in the slit lamp. So therefore, OCTs are very valuable and detecting them earlier. And why is that important? And one of the studies that we looked at a couple of years ago with my colleagues in here in the University of Illinois, we looked at this correlation then that showed us that the membrane thickness was significantly greater in eyes that developed melt compared to those that did not. And the range was about 278 microns, which is surprising to you, right? I mean, this is almost, in some cases, half of the corneal tissue. And surprise you even more is an example here of a case to which of an extruded capro. You see the OCT image here with complete loss of tissue next to the optic itself. And as we remove, the actual membrane is as thick as the cornea itself in an eye that was extruded itself. So again, these membranes, as we theorize, as they develop, they envelop the surface of the most interior, posterior surface of the capro, and that perhaps hinders or inhibits any nutritional components that would be in contact with the tissue, and therefore develops this chronic melting over time. So, and then as far as the study that we looked at here in RPMs, they were present, like I said, in 38 eyes, 22% of the cases. The mean time developing these membranes were 13.2 months. No statistical significance between difference among preoperative groups in these cases. So what about melts in the cases that, or in their review they did of the study? When Capro is working for us, it's fantastic. The tissue stability, proper retention, there's no thinning or melting. But when we do have these melts, as you see here, that's sort of the course that follows if you don't treat them aggressively, is perhaps extrusion in some in cases like this. And you see the OCT with total loss of tissue. An example here of extrusion of the capro itself. So it was reported in our study in 60% of the cases, more commonly presented in chemical burn group. In the meantime to presentation, this is important because we have to sort of have an idea when we start looking for these things to happen and perhaps make our follow-ups perhaps at a shorter interval. The mean time in this case was 26 months. In other words, the first within the 3-year period or so. As far as melting, there was, again, in the first year, we saw 12 of them, and between year 1 and 3, 7, and then after 3 years, 8. So basically just scattered throughout time. But as I said before, you want to also look at that RPM developing in thickness, and that might be a correlation between the development of RPM and the melting happening in these cases. Autoimmune cases, perhaps you also have to keep an eye on, even though there's no significant difference in between groups here, and also in the period of within time as far as melting developing. As far as infections, we grouped them together between keratitis and endophthalmitis, and we had a pretty low rate, which is good, reported in 8 eyes at 4% of the cases. And in review of the colleagues and the surgeons in Latin America, they were pretty consistent in the use of vancomycin or a combination of vancomycin and fluoroquinolone, so that perhaps has been a factor. We did not see, as we had seen in other regions, a greater increase in the fungal components, but it's something that we still keep an eye on. And I know in some other regions that the use of fungal treatments at burst, let's say every 3 months or so, has been used. But so far in the region of Latin America and South America, we've not seen that greater of an increase as has been in other regions. And as far as extrusions, would have mean time extrusion would be the 36 months. And you see here, right here is pretty low, but still significant, and something that want to be aware of. What about glaucoma? Is something that we're still working on the study itself, something that we've seen so far. And just as an overview here, what do we do for glaucoma, or how do we measure, how do we follow it? As you know, you can't do a tonometry over a keratoprosthesis because it's basically a hard surface. So other options that we do and we recommend is use a pneumotonometry in the sclera or sclerocorneal junction, and that's pretty significant. That's pretty good correlation in the average pressures. Once we go to 60, then it's a wider range, but something that you can consider as an alternative to just finger palpation. No doubt that Goldman or Herman visual fields are very valuable in the progression here, and imaging is something that's very valuable. But I have to caution you that I would not follow up these patients as you would a regular glaucoma patient, because the progression of glaucoma in keratoprosthesis is very dramatic and rapid. Therefore, if you're used to following somebody every 6 months for a pressure check, I would suggest that you start following them first every month. And if you're comfortable, perhaps 3 months, but not certainly a longer period of time if there's showing suspicion. So just an image here, not just so we treat them mostly with topical and perhaps in communication by mouth, but the glaucoma tubes are recommended in these cases, and we recommend also that we do pars plana placement so we don't disrupt the placement of the contact lens itself. And this is, for example, in this group, we had basically 70% of the patients in non-inflammatory group are the ones that had glaucoma, and you see that the division here over time. So in conclusion, K-Pro type 1 provides an improvement in visual acuity, which is stable during time. The mean follow-up in these studies was 38 months, which is something that's pretty significant in regards to what we want to see. Certainly want to continue following them up, but 31 eyes had a follow-up of greater than 5 years. And the global retention, which is pretty good, is 93%. Now, as we add more cases here, I expect the global retention to vary also, and also the rate of RPM and so on. But the infection one component and just the initial review that we had and the additional 100 cases that we added it remained the same. So I think it's a pretty encouraging data that the regional study that we have here shows comparable results to the ones that have been done in North America and other regions. And also, I think in other components, for example, in infections, it shows that perhaps we're not having the issues that we had in other regions in regards to the need or the presence of fungal components and infections, which is something that we can actually use in a regional way rather than applying global data to regional components here. So it's a great pleasure. This is the surgeons that so far have been contributing to the study, and it's something that continues to grow. We like to be always very inclusive in the sense that we want to continue adding surgeons and data. So it's an ongoing study that hopefully will give us continued information, not only for the global component, but also for the regional surgeons and how they should treat their particular patients in their regions. So obviously I'm making a plug here for our book of keratoprosthesis and artificial corneas, which gives you all the information as far as implantation and managed complications with my colleague, Dr. Cortina. And it's always a pleasure to be with you guys here today. Thank you very much for your attention.
Thank you, Dr. De La Cruz. I have a question for you. What is the reason behind the excellent outcome in this in Latin America? The global rotation was around 93%, the low incidence of infection. This is the best outcome all around the world, maybe.
Well, I mean, I would say it's comparable. There's certainly like different types of, if you look at different data sets, for example, the ones from our colleague, Dr. Aldawi, has a pretty good low rate of infections. And as you look over time, I think these things change. You know, we can't really judge it from the period that we have right now. And you can't really call it a victory, but at the same time, it goes to the point of, you know, the surgeons being very diligent in their region and having the precautions to perhaps shorter follow-up periods, consistency in the use of antibiotic therapy. And because as you look at, you know, I've looked at the different papers and even abstracts and so on of infections, it's say in our regions, in the United States. And one thing that I've noticed that sometimes we get a little lackadaisical and we stop using vancomycin and relying perhaps only on the use of a fourth generation fluoroquinolone. And then consistently what I've seen is that these papers show that when you start using those in perhaps patients that are high risk and you have a shorter or longer period of follow-up, that's when things might sneak in and happen. So I wouldn't say, at this case, I think it's just basically being the diligence of the surgeons and seeing them a short interval. And what we have to look more into it also in regards to, is it truly a regional thing that basically protects them in regards to infections? I doubt that it is, but I would say that at least from the data that we have here, it's just been the short interval of follow-up and then consistency in the use of vancomycin in these cases.
Even though it's amazing, no? Global rotation, 93% at year 5. Nobody have this rotation rate all around the world. More or less around 85, the highest. But it was.
Well, remember, we're still adding cases, so that I'm sure that's gonna vary. Hopefully, it'll stay at a high rate, but it'll vary.
Jose, can I ask a question about the same topic? Do you think also how is the contact lens management in Latin America here? Sometimes we don't have the the control lens that you have in the US. So people use disposable contact lens, also the treatment of povidone iodine during the visits. Did you check through these details?
You know, these are details that we're going through the second update, but just to comment on that, you know, we actually, a lot of our patients here in our service end up not wearing a contour lens. Because remember, use a contour lens, so that's one that comes with the keratoprosthesis, but doesn't mean that's the one that's optimal for every case. So the contour lens we start with, and that's obviously a greater size lens. But I couldn't say that that lens is more protective than any other lens that you'll wear. I think the optimal lens is the one that patient feels comfortable with, that stays in the eye, and that perhaps if a patient has a tube and so on, that's the proper diameter. So that being said, you know, a lot of the patients that cannot wear contour then wear just a disposable lens that's just as effective as the other lens, because we want to just keep sort of the surface from desiccating. And truthfully, I mean, in some cases, we just don't use a lens, we just do a torsorrhaphy. And that we get a good protection on the surface, so we minimize the desiccation of the surface and perhaps minimize any problems here in these cases. I mean, your other question, I'm sorry, was the contact lens, and as far as, what was the other question?
Povidone during the visits.
Yes, that's something that actually has been adapted more and more. And that's one other question that we added to our Excel sheet, is that how many people use povidone iodine during the visits itself, and that's something that's becoming slowly more accepted as part of your regimen when you see the patient. I've been working with a group that's actually using a povidone iodine at a lower dosage in a gel, and in my high-risk patients, I've been using that once a day for a week and then every other day, and it's been very effective in keeping the ocular and the lid surface pretty healthy, and also minimizing any type of possible infections.
Yes.
The argument against that also is, you know, as you heard some people, that as you use a lot of this povidone, you might deactivate any of the medications, but that's something it's a different discussion, I guess.
Yes. Can I ask a question to Virender?
Of course.
Virender, can you comment on the niche story? I mean, comparing SLET versus conjunctival limbo grafts. With the conjunctival limbo grafts, you are transplanting the limbo niche.
Yes.
SLET, you don't do it. Do you think it can make a difference in the long-term results?
No, first of all, Jose, I think in limbal, in SLET, we do transplant some part of the niche, because the biopsy is about 50 to 80 micron thick. So it's not pure epithelial cells. It's a mixture of mesenchymal cells, ECM, melanocytes, and other cells. So,
but you transplant the limbo structure, which is also important to maintain the stemness of the cells.
Yes. So this will come useful if there is a extensive damage to the limbal niche in the recipient eye, where the success, you know, these 15 to 25% patient who fail, in my view, that is mainly because those who have extensive damage to their ECM and their niche area. So even after putting the limbal epithelial stem cells, they may not survive there. Now, to compare this with the CLAW versus SLET, I think it's not a very easy comparison, unless we do some very ultra high structure studies using, say, for example, electron microscopy, and then trypsinization of the tissue and see what is the architecture, or ECM, after decellularizing these two biopsies, which is possible to do. And maybe that gives me an idea that I can think of doing a decellularization and then imaging them in a CLAW piece and a SLET piece. What is the difference in the ECM?
Okay, thank you. Dr. Sang, one other question. You have also a large series about the SLET after failed.
Yes.
Could you explain us what is the selection of the patient or what?
There was only one selection criteria. The patients which failed in my hands with CLAT, because we are doing a fairly large number of CLAT for almost 8-9 years. So then what I started was offering SLAT. And I thought that, you know, this surgery might work differently. And that's what you see the publication in, I think, in BJ or AJO of 30 eyes. And I'm quite pleased that the success rate is quite good.
This is excellent. It's so high. It's excellent. We are treating the end-stage ocular surface disease. There is 2 factors that affect the outcomes finally. One is the dryness and keratinization, and the other is the inflammation and etiology of the limbal stem cell deficiency. I have a question for all of you regarding the dryness and keratinization. What do you prefer first? What do you prefer? First, you will treat the ocular surface, stabilize the ocular surface, or you prefer to go directly to other kind of keratoprosthesis, for example, the osteodontokeratoprosthesis that they have a lot of experience in India.
In my view, can I just make a comment? In my view, when you see keratinization on the ocular surface, that is a sign of extreme distress of the ocular surface. And you should think of doing optimization procedures before doing any intraocular or surface procedures. So you should try to address why it is happening, if it has happened, how you are going to deal with it. Say, for example, in patients with SJS, we do mucous membrane grafting on the lid margin, a release of symblepharon using the mucotome harvested thin mucosal flap, which Jose showed in his video. Please, other panelists, please comment.
Yes, I think it's a great question. And I think you need to, and we learned that Virender can also, Virender and Jose also can speak, and you also, Hernan. We know by the experience that you need to do a stepwise approach. You need to deal first with the leads, then lubrication. I think it's and a keratinization is a sign that it's a very severe case of dry eye. So we learned that salivary gland transplantation helps a lot to improve a little bit the lubrication, so you can put cells on the top of the surface. If you do not deal with the leads and the lubrication, you cannot move to the ocular surface transplantation. In parallel, you need to also try to get the best you can the control of inflammation. So then you go for the ocular surface reconstruction, and in case you need, then you go for the cornea or a K-Pro. But even for the K-Pro, if we improve the environment, then you can have a much better retention in this K-Pro or the cornea. So I think that's the stepwise that you need to do in these patients.
I agree. When you have, you know, as Dr. Sangwan and Dr. Gomez had mentioned that, you know, if in fact, when you have keratinization, it's actually something that I'm concerned about if I'm considering keratoprosthesis, because that's going to basically limit the success long-term of the stability of this K-Pro over time. So certainly working on the ocular surface, optimizing it, because remember, the K-Pro, at least the type 1, and you have to have some type of moisture in the surface to really keep the stability and avoid desiccation, and then minimize the risk of retraction of the tissue, having infections and so on. So, you know, when you have keratinization, you have to really be aggressive and try to rehabilitate the ocular surface as you can if you were to consider down the line a keratoprosthesis. So all other ocular surface procedures should be maximized before you even consider the keratoprosthesis. And if you cannot optimize that, then you're thinking already about, you know, things like type 2, very aggressive dorsophies to really maximize the success long-term of the K-Pro. Otherwise, it doesn't matter what lens you put in, doesn't matter what you do, that you're going to deal with long-term issues or maybe short-term issues with the K-Pro, with the keratinized surface.
Yeah, let me, totally agree with Jose 1 and Jose 2. Selection of the patient for Boston K-Pro is very important. We already know that the cases with severe conjunctival inflammation are poor candidates for this. Even so, we try to get the patient in the best condition that we can do, even either with a topical medication or systemic medication. Something that we really care here at KKESH is that we make sure that the patient that we're going to be doing surgery has visual potential. Most of these patients has a lot of expectations. So what we do here, if we're not sure if the patient is going to improve, we go ahead and we do a microendoscopy. We had a paper with Victor, I don't know if Victor is still there, where we analyzed the patients that were candidates to go for Boston K-Pro, and we do B scan, we did B scan of those patients. And this is a short series of 10 patients, and we did a B scan in 10 patients. Out of those 10 patients, the B scan showed that 8 of them were candidates to go ahead for Boston K-Pro. Then we did 5 cases were done in my clinic, 5 cases were done in Bascom Palmer, and then we did microendoscopy, and we found out that out of those 10 patients, only 3 cases were candidates to go for Boston K-Pro. The other ones has chronic retinal problems, macular problems, and optic nerve problem that they were not going to improve with the Boston K-Pro. The other thing that is very, very important for Boston K-Pro is the follow-up. It's not the same that you lose a patient with a graft that you lose a patient with a Boston K-Pro and they don't come for the follow-up. Patient with a graft might come with a failed graft, poor vision. Patient with a Boston K-Pro might come with a Boston K-Pro in the hands. So this is very, very important. And because of that, we create King Carlisle Hospital, keratoprosthesis clinic more than a year ago. And this is me and Dr. Osorio working on it. And we see almost 40 patients per month. We see new patients, we see follow-up. And the important thing about this is we really try to keep a regular follow-up for these patients. So we see this patient depends on how bad they are. Some of them are very good and we don't need to follow them very close. We follow them every 8 to 12 weeks. The rest of them might come every 6 to 8 weeks. So I think that this is very, very important for the survival of the Boston K-Pro.
Yes, and also our complication rate is so low right now. When we start with the K-Pro clinic, right now the complication is, the big complication, is really low. Okay, Dr. Barrel, we're gonna move for the cases.
Okay, give me 1 second. All right. Thank you so much for the opportunity to be here. My case will be, yes, it's good. My case will be a clinical case of a Boston K-Pro. I have no financial conflicts of interest to disclose in this presentation. And as it was mentioned before by my good friend, Jose de la Cruz, the Boston K-Pro is an excellent alternative for patients that we know that if we do a regular graft, they will fail. So the Boston K-Pro is one of the best, and actually is the most used alternative for patients that have bad prognosis for regular graft. So I have a patient here that, let me say 1 second here. Wait, I'm trying to get this out of my screen. Minimize this for me, please. All right. Give me 1 second. Okay, here we go. Okay, so this is a 74 years old male who presented to my clinic complaining of decreased vision and teary for the left eye. Accompanying symptom was pain, severe pain in the left eye. The past ocular history, patient had cataract surgery in both eyes, had a retinal detachment surgery in the left eye in 2014, had secondary glaucoma in the left eye, also had multiple graft failure, 2 graft failures in the left eye, also had a corneal melt, and the corneal melt was glued in 2015, as you can see in the picture. And then we did a Boston keratoprosthesis, combined with glaucoma surgery and implantation of a med valve. The ocular medication by that time was based on lubricants, moxifloxacin twice a day, vancomycin. We use 25 milligrams ml once a day. We don't have the possibility of using 14 milligrams by ml twice a day. So we use the vancomycin 25 milligrams once a day. And also the patient was under treatment with anti-glaucoma medication. Visual acuity of this patient was hand motion in both eyes. The patient had a severe glaucoma damage in the right eye. Even so, the pressure was controlled at that time was 18, and the left eye has a Boston K-Pro, and the digital pressure was hypotonic, very hypotonic. Extraocular muscles were full and no nystagmus. Lids and eyelashes were normal, both eyes. The conjunctival sclera, only positive was a moderate injected conjunctiva in the left eye. Cornea in the right was opaque, it was hazy, and in the left eye there was a Boston keratoprosthesis, and also there's a positive find that was a host corneal melt at 6 o'clock, and with positive Seidel test. Anterior chamber was no view in both eyes. Iris and lens, no view in the right eye due to the corneal opacity, and the patient was affected in the left eye. This is a B scan performed the same day. As you can see, there are a lot of scleral folds, which tells you that there is a very severe hypotony in the eye. And this is the picture when this is the first time that I saw the patient. That's February 3, 2016. In the left eye, there was a hand motion. So if you see a case like this, you will know that the only alternative for this patient is artificial cornea. In my case, my experience is with the Boston K-Pro and the KeraClear, but here only available to use the Boston K-Pro. So I decided to go ahead and do surgery for this guy and implant a keratoprosthesis, which I did in January 23rd, 2017. And from hand motion, we went to 2200. As you can see, this is a one-day post-op. It's a beautiful view of this Boston K-Pro. Then the patient came months after that, March 6, 2017, complaining of decreased vision, tearing, and pain. And as you can see here in the picture, you will see that inferiorly there is an area of melting, which caught my attention. The area of melting is not an area of melting of the donor tissue, which are where I'm expected to see the melting, because this is the place where you will see the RPM, and you will have the back plate, decrease of the nutrition. But this time the melting was inferiorly at 6 o'clock area, and it will go from 4 to 7, almost 8 o'clock. So as you can see here in this picture with fluorescein, it shows you that positive Seidel test. So the diagnosis of this patient is a corneal melting after Boston keratoprosthesis with positive Seidel. And the discussion for the panel is, what are the surgical options that we have for this patient? The surgical options when we have a patient with corneal melts are going from suture. You can suture the area and stop the leaking if there is a leaking, or you can glue the affected area. You can go ahead and do a lamellar patch. You can also do, go directly on the keratoprosthesis, so you can do a K-Pro removal and a therapeutic PKP, or you can do a K-Pro removal and you can reassemble this into another new cornea using the same K-Pro, or you can exchange the K-Pro and put a new one with a new tissue, but you can also do cross-linking. So my question for the panel, what will be your surgical approach?
Jose, I think in the initial cases, maybe you can also add a neuromucosal graft. Sometimes it can be helpful. But when you have a lot of tissue loss, then you can do the lamellar patch. That can be an option, trying to preserve the structure of the cornea, the supporting cornea, before thinking about changing to another K-Pro, maybe with a cross-linked cornea. You also need to identify the cause of the melt. If there is any, you know,
and no comorbidity, except the fact that the patient had an area which we identified twice. The patient had an area of delling inferiorly due to dryness. This patient had tarsorrhaphy a couple of times, temporal tarsorrhaphy. Unfortunately, I don't know, this patient found the way to disrupt the sutures and coming all the time with the eye open. So I believe that the reason for this corneal melt, it was a severe area of dryness inferiorly, and this is the place where the melting starts.
So I'm sorry, I forgot the diagnosis of the patient was?
This patient was a multiple graft failure.
Okay, no history of herpes, no history of other diseases that could potentiate the melting process?
No.
And you had doxycycline, you put all the...
Yeah. We did everything for him. We did Provera, we did doxycycline, we did lubricants, and we did steroids. We did everything for him.
See what happens is in these patients, if there is a epithelial breakdown for some reason, or loss of contact lens, or the tarsorrhaphy gives way, and once the epithelium starts breaking down, it's sometimes very difficult to heal, and they start melting quickly. So I would try to salvage this K-Pro if the useful vision is still there, and there is, there is a way of doing some sort of a patch graft or a the cyanoacrylate glue. Then see if it improves and the hypotony or pressure is maintained. You can continue that way. Otherwise, if this is the only eye and it doesn't seem to be responding to all these things, then either do a keratoplasty, therapeutic keratoplasty to save the globe, or replace with another K-Pro with a larger graft.
Okay. So, do you have any experience with oral-mucosal graft to cover the area, like in this case, in which it has a lubrication problem, and together with the tarsorrhaphy, it also may be an option. We had a few cases that we could preserve and stop the melting process, covering it with oral mucosa.
Here, because there is a hole in the eyeball, so that is something that you need to seal. But what I do in some of my patients is, if I can mobilize the conch, I try to cover the graft host junction and debride the corneal epithelium and cover as much as the graft, so that the graft host junction is well covered with a conjunctiva.
Absolutely. One here that we cannot get more information is that I want to note on this is you have a titanium backplate. Therefore, if you were to image the eye and see what's happening behind it, you don't know if there's any membranes behind there or not. So having a titanium backplate sort of limits your view. I agree with all the comments here. I mean, I would still dig in regards to other inflammatory components. As he had a test for RA or any other issues, or he had any trial of pulse of steroids by mouth in these situations, and see if this inflammatory process decreases. In regards to the immediate care, it's depending on what you have available. I mean, if you have a K-Pro available, of course, you can have the luxury to replace it. But certainly glue works very well as an immediate thing to stop and then temporize things while you plan your surgery more effectively, or a lamellar graft in the area with glue in the air, surrounded by glue. But I agree, depending on what you have available, depending on the immediate urgency that you have here, would guide the approach that you do here. As far as cross-linking, you know that there is now a study in regards to the efficiency or the effect of cross-linking in tissue like this, and minimizing the possibility of melting in these situations, but you don't have a clear answer on that yet. So that's yet to be seen in regards to long-term effect of it.
Yeah, this patient clearly have only localized melting. The melting is only inferior, and Dr. Vargas explained is more related with exposure. You can see the eye is wet. I don't think so. The problem is the lubrication. Maybe in this patient in the hospital, unfortunately, we have in the eye bank, we have patch. I'm gonna go for this patient for lamellar patch, and I will try to reconstruct the inferior cornea. Later on, I will also mobilize the conjunctiva to the border of the K-Pro. Mobilize also the conjunctiva to the border of the K-Pro in the same way that Dr. Sanwat described. This is both procedure combined, lamellar patch and also conjunctival graft is lower in these kind of patients.
And one thing you need to be sure that there is no infection. Always when you have this continuous melting with epithelial defect that never closes, it's good to scrape and do cultures as well. Sometimes you can identify the very low pathogenic fungal or bacteria that you need to rule out.
Yeah, in this case, no infection associated.
Mm-hmm.
Any other idea? Although I don't know if Dr. Alios is still there. Victor, are you there?
Consider doing tarsorrhaphy, a permanent central tarsorrhaphy rather than a lateral tarsorrhaphy.
Yeah, that could be done.
In his case, we had temporal, nasal, and temporal canthus temporary tarsorrhaphy. It was nasal and temporal.
No,
Okay.
consider doing permanent and central, because
now what we do in these cases is we do permanent nasal and temporal, and we leave only the central part of the eyelids free for treatment and free for the vision of the patient. Okay, so what I did is, this is the surgery. I started doing aperitomy, inferior and inferior conjunctiva. Then I went as much as I can to the fornix and to order to make a flap. Then I need to get some cornea in order to make a lamellar graft for this patient. So as you can see here, I have a ring, and the ring has the total diameter of 12 millimeters, and I did a central trephination of 9 millimeters. So I have a rim which is 3 millimeters in wide. So this is the ring that I'm going to use as the lamellar. Then I try to get the size of the area that is affected. And because I know that it's a very, very thick one, I need to do a lamellar dissection of this flap in order to make it able to place it into the area that is melt. The other thing that is important in this area is I get a crescent and I scrape all this area, also to get tissue for culture and also to remove all the melted tissue and necrotic tissue that we have inferiorly. Once again, and measure again, I need to be maybe a little bit bigger than the size of the melting area. I know that the surrounded area has the normal thickness. So I want to be at the same plane when I suture. So this is, I suture this to the receptor, and then I cover the area with a Gunderson flap and suture the conjunctiva. And then I need to cover the scleral that is exposed. And I cover that area with amniotic membrane and T-cell. And I also cover the rest of the eye with amniotic membrane. And then a contact lens. So this is the result after 3 days. As you can see, this is very nice integrity, the contact lens in place. The vision is hand motion, but just remember that we have amniotic membrane covering the optic of the K-Pro. This is a few days after the surgery on March 12th, and you can see a normal B scan of the patient. This is 1 month after the surgery. You see the integrity of the eye. It's still a little bit red, but it's a quiet eye. This is a cassia OCT of the cornea. We didn't get the size where the mel was, but the area where I did the graft kept the good thickness. So that means that there was no melting of that area. And this is on October 15, that's 7 months after the surgery. Patient has an uncorrected VA of 2160. Unfortunately, the patient also has severe damage of the optic nerve, so we couldn't get a better VA, but it's a one-eye patient with 100 and vision of 2160. After this is a really good achievement. Thank you so much.
Good.
Yeah, fantastic outcome.
Yes.
Yeah, you see that the mucosas, they help a lot to, you know, when you do the procedure to cover the area with vascularized tissue. Here you had the conjunctiva available, which was great, as Virender proposed, and you did. But sometimes when you don't have a good conjunctiva, you can also use the oral mucosa as well. Very nice case.
Excellent outcome.
Thank you so much. Even let me add something. We have, I don't know how many cases we did, Jose, while you were here. I see that we do a couple cases with oral mucus for ocular surface reconstruction before the Boston K-Pro. Actually, one of these patients had, he had Steven Johnson. He was blind for 37 years bilaterally before I did the Boston K-Pro. You did the mucus, I think 6 months before I did the Boston K-Pro. It's a spectacular result. Sometimes I will show you in one of these meetings how dry the ocular surface was, not only dryness, keratinization. This patient now is 20/30 uncorrected. This is 2 years after the surgery. It's an excellent result. So I totally agree with you. Oral mucosa is an excellent alternative for these patients.
Okay, I'm gonna try to share my screen. Let me try, because I have the first time I will do. Yes. Okay, now again. Yes, perfect. Can you see my screen?
Yes.
Yes.
Okay. Perfect. I will start. Talking about the surgical treatment of the ocular surface disease, other important thing is the cataract surgery in this kind of patient. So I will show you a patient of 61 years old who have a first episode of epithelial defect in 2013. He was diagnosed as BKC and treated in private clinic. Later on in 2015, they started with PED, and we was treated in a governmental hospital. And finally, on November 2016, the patient was sent to our hospital. The patient came with bilateral PED, discharge, severe eyelid edema. The patient has diabetes, is heavy smoker, have hepatitis C partially treated with interferon, and also TB partially treated. During that time, the examination, the vision was 2040 and 2200. The patient has severe eyelid edema, superior tarsal papillary reaction, nothing blepharon, mild mucus discharge, wet eyes, and a sterile superior chill ulcer in a mild cataract. The IOP was high, around 25. The fundus was normal. It was diagnosed as a chill ulcer secondary to BKC and a responder. The patient was treated with bandage contact lens, prophylactic moxifloxacin, cosopen lubricant, and 10 days later, the patient healed and came back to his town. 3 months later, the patient came again to the ER or our hospital with pain, itching, worsening of the chill ulcer with white discharge, and increase of the eyelid edema. Corneal scalpel was done and showed an MRSC resistant to moxifloxacin and ofloxacin and penicillin. This is the photographies of the eyelids. You can see the eczematous dermatitis and the severe edema. This is the conjunctiva. Unfortunately, I don't have photographies of the superior tarsal plates, but they have a moderate papillary reaction. You can see here a moderate also meibomian gland dysfunction, but there is no symblepharon and there is a moderate inflammation of the conjunctiva. This is the chronic ulcer in the eye. You can see the stromal also was compromised. This takes time to have this appearance. This is the OD with the visual acuity of 20/80. And the left eye had the same appearance. The vision was worse because the compromise of the visual axis was 4/200. The V scan was normal. We did a orbit CT scan, and the CT scan shows enlarged lacrimal glands. The chest CT shows also pulmonary fibrosis with bronchiectasias and some bullous. You can see one here, on other here, centriacinar bullous. Then the first question for the panelists is, which investigation will you request, and what is the probable diagnosis of this patient?
If you have this history of itching and this ulcers which look like seal ulcers, so it's an allergic eye disease, which seems to be very neglected and not treated, at the appropriate time. The ulcer seems chronic, so I would treat aggressively, after ruling out if there's any infection. And sealed ulcers are generally not infected. Only sign if they are infected is you see some cells or hypopenia in the anterior chamber. In those cases, you need to scrape or send the material for microbiology. Otherwise, I would give systemic steroids and intense topical steroids. The plaque looks like Cameron's classification type 3. So I would have to excise those plaques and use amniotic membrane and possibly combine with a supratarsal steroid injection.
And regarding the diagnosis, vernal keratoconjunctivitis at almost 60 years old patient.
Yeah, in India, in Middle East, in Africa, you see these patients adult onset of VKC also. And now there are some reports from the Europe of VKC, adult onset VKC.
Okay, Dr. De La Cruz.
Hernan, can you speak more about the pulmonary lesions? It's very,
The patient was treated of TB, partially treated TB. And
TB?
Patient had, yes, TB and heavy smoker. Which
as Virinder said, we also had, it's rare, but we can also hear VKC in older patients. But, with the enlarged lacrimal glands and pulmonary lesions, you can also, consider other diseases. For instance, I think sarcoidosis or lymphoproliferative lesions. This patient needs really to investigate more systemic conditions that may be involved in the picture. Yes. Considering especially also the rarity to have this presentation in a patient that is a little older. Did you make other tests, serological tests and imaging tests?
I will show the systemic workup. Jose De La Cruz, any thoughts?
I'd like to get more information in regards to what systemic workup this patient has. Absolutely.
Okay, I'm gonna follow. So the patient has an IgE so high, 8,600. The uric also was high. The RAS was positive, very positive. Different food allergy, positive dermatophagoids, also alternaria, aspergillus. The patient, of course, they have antibodies of the hepatitis B and C. The ACE was normal. ANAS was normal. The rheumatoid factor was positive, 120. And the patient in the HLA typing, we discovered 6 different markers of predisposition of autoimmunity. That this is so strange. The quantiferon TB gold was also positive. The ANCAs were negatives. the protein electrophoresis was normal. And finally, we did the lacrimal gland biopsy. The lacrimal gland biopsy, they shows an infiltration of chronic inflammatory cells, lymphocytes, plasma cells, eosinophils, but no vasculitis. This is the CD34. And the diagnosis was highly consistent in Sjogren syndrome. This is what the diagnosis at that time in the hospital. So the patient was diagnosed with AKC and Sjogren-like syndrome because the patient had hepatitis C. The treatment was started. Dr. Someone told us that prednisolone, higher doses, levocetirizine, topical, we start cyclosporin, remexolone, epinastine, autologous serum because of the large ulcer, vancomycin, remember the patient have MRSE, COSOP, preservative-free lubricant, and the treatment of the meibomian gland dysfunctions. 2 months after the treatment, of course, the cornea heals. The patient have this, you can see the cataract here, white, after only 2 months of treatment of the systemic and topical corticosteroid, and the Denny Morgan falls. So for us was clear, the patient improved. We sent the patient for the allergologist and the immunologist, and the patient came 3 months later with this report. This was an amazing that they were thinking that the patient have a topical ophthalmic drug-induced Stevens-Johnson syndrome. They also discovered an allergic reaction to the ceftriaxone and third-generation cephalosporins, and they request all the information about the topical treatment, mainly the serum, the autologous serum, and the cyclosporin. This is now the again question for the panelists. What do you think? This is a Stevens-Johnson secondary to the autologous serum or cyclosporin, or this is still the diagnosis of AKC and Sjogren-like syndrome? Have you seen before Stevens-Johnson syndrome secondary?
Sure, the Stevens-Johnson's, I mean, the Sjogren was confirmed, right? Sjogren's can cause enlargement of this lacrimal gland, can cause the problem in the ocular surface, dry eye, can cause the pulmonary lesions, and together with the AKC. But the Stevens-Johnson's, I mean, I didn't understand how you made the diagnosis based on.
This is what the diagnosis was made by the immunologist in his local hospital.
No, I don't think this is SJS, and other findings of lacrimal gland and chest are, to me, are secondary. I think it's a emergency with bilateral corneal problem. So we must aggressively treat those and with the systemic steroids. And other things I would investigate and pursue once my corneal situation has improved. I think here the more important is to save the corneas.
I agree. Okay, so this patient, we did a reassessment, and the patient, he was taking allopurinol that started in 2013, 1 month before the first episode of the epithelial defects. And every time the patient reassumed the medication, they have worsening of the ocular surface. It's not clear, really. And this is what's a reassessment. Nobody was asking the patient before about the specific treatment. But the patient, when we talked with him, he told us that every time that he resumed the allopurinol, he had worsening of everything. We continue the treatment with the cephalosporin, cyclosporin. We switched the topical corticosteroid for the meroxyprogesterone, epinastine, COSOPs. We still the preservative-free and the meibomian gland dysfunction treatment. And finally, the patient came with a eyes, with the white cataracts, and the vision had motion. The patient had the same vision for the last year, was almost blind, was blind for 1 year. As now, the patient in my thoughts is the patient is ready for cataract surgery. So the last question to the panelists is, what is the consideration for the cataract surgery in patients with severe ocular surface disease?
Only thing that you want to make sure that surfaces doesn't have an active inflammation. The corneal epithelium is quite happy. So you would want to use topical steroids or lubricants or both before the surgery. IOL power measurements may not be accurate because of the previous corneal ulcer and scarring. So you may, try different techniques of measuring the IOL or do the best you can, and go ahead with the regular cataract surgery.
Yes, the only thing sometimes I do with with autoimmune diseases is I increase the systemic corticosteroids just before the cataract surgery and keep for at least a few days after the cataract surgery to control the impact of the surgical trauma. Even being a small trauma with a phaco, that would be the preference for not stimulating the immune system. I like to increase a little bit the systemic control of the immune disease with steroids.
Agree. I mean, anybody had any concerns or would do a scleral tunnel versus a corneal incision, and with the concern of that perhaps that cornea healing process being active?
But what do you think? How many months does it take for the stabilization of the ocular surface before we're gonna go for the surgical approach?
Well, I think if the cornea is fine, if it's not too thin, I would prefer to use a corneal incision, because you don't need to make any trauma in the sclera. So I would go for a corneal incision, small incision, the smaller you can. Despite this is a very dense cataract, but even so, I would try to do cornea if the cornea has good thickness and if the inflammation in the ocular surface is controlled.
Any thought about how many months? 3 months, 6 months?
No, if you have active inflammation, then you need to wait. If the inflammation is controlled on his maintenance therapy, then you don't need to wait further. If the corneal surface is shining, your Purkinje images are well focused when you do the slit lamp examination, then you really don't need to wait extra.
Okay. This IOL calculation was done several times. This is the more stable IOL calculation, but even that, I couldn't find the pentacan, unfortunately. I don't know why. But the patient have high astigmatism, but I don't think that the patient will have some benefits if we try to do a toric IOL. So this is the surgery of the patient. This is always in this. I agree with Dr. Gomez. I prefer a limbal corneal surgery, a limbal corneal incision. I don't go for a scleral tunnel. I prefer to do not touch the conjunctiva. This is a white cataract. This is the surgery was done with vision blue in this case. The surgery, also I did the surgery in a slow motion. I did the surgery so slow. I try to avoid any complication. I don't imagine if the patient have a drop nucleus, what happened if we're gonna try to touch the conjunctiva and try to do a vitrectomy. The surgery was really slow. In this case, I did a vertical chop. I put over the cornea methyl cellulose. I was not using the BSS, only methyl cellulose. I tried to protect my epithelium. The surgery was, you can see, this is really, really slow surgery. I spent, I don't remember, more than 20 minutes in this surgery. I did the surgery really, really slow. The pupil was stretching, was not cooperative. Unfortunately, the patient also. I always do bimanual irrigation and aspiration. I try to reduce also the inflammation in the postoperative time. Try to do a really, really good aspiration of the cortical material. Through this small pupil, I insert the IOL in the back. I was sure that the IOL was in the back. I am not showing in the video. And finally, I did the aeration of the incision. And I also remember that this patient it was a steroid responder. I removed the viscoelastic. When I was sure that everything was okay, I finished my surgery. Okay, this is 3 months after the surgery. The eyes were quiet. The vision was 20/60. The patient was happy. Finally, the patient recovered his vision. This is in the last appointment in April 2019. There is the superficial glaucoma in the superior cornea with tiny limbal stellate deficiency, and the vision of the patient was 20/40. This is dilated. You can see the IOL, both IOLs in the back. The ocular surface also was quiet. And unfortunately, in the right eye, the patient have a large cup because of this steroid responder, the glaucoma that the patient developed finally along these 4 years of treatment. This is what is the take-home message for this patient, that the chill ulcer is an uncommon manifestation on AKC. 5% of AKC patients are not associated with atopic dermatitis. I forgot to mention that the patient never had atopic dermatitis. Epigenetic factors as smoking, the HLA predisposition, the hepatitis C, even the TB, can worsen the inflammation. We have to take care about these epigenetic factors. Infection in MRC on MRSA is more frequent in AKC patients and severe ocular surface disease than normal population. We need a multidisciplinary approach always. We need to treat this patient with the rheumatologist, with the immunologist, with the allergologist. And severe ocular surface disease should be optimized at least 3 to 6 months before the cataract surgery. When you are really sure that the surgery is the ocular surface inflammation is well controlled, later on you will do the cataract surgery. So this is the case that I show you and I prepare for this webinar.
Thank you. Great case.
Thank you. Dr. Vargas.
Yes, thank you, Osorio. Very challenging case, not only to decide the technique, also to get the real diagnosis of the patient. So I think that we don't have any more questions or any more comments. I really appreciate everybody of the speakers for attending this webinar, for King Khaled Hospital, for KKESH Global Education Forum, and for the Anterior Segment Division. It was a great pleasure to have you guys here today with us. We had more than 300 people attending and almost 700 people registered. More than 300 attended, which is a very good number. I'm sure that everybody who attend this webinar benefit for all the knowledge that came out of here. Jose, thank you for helping me, the organization. Jose de la Cruz, thank you for accepting the invitation. Jorge and Victor, thank you so much. Jennifer, thank you. Dr. Virender, thank you so much for accepting the invitation as well. And Osorio for helping to moderate this along with Jose Gomez. Thank you so much. We'll see you in about a week that we will have our next webinar. Hope to see you guys there. Thank you so much.
Very much.
Have a
Thank
good
you.
morning, good afternoon.
Thank you. Bye.